And only 30 seconds for the judges. हाँ, कौन जीता वही तो बताना. All right. I would request Dr. Anuja to please get started. Your time starts in 3, 2, 1, go.
Very good morning to all. Today we are going to discuss a very interesting topic. On the debate is whether we should go for cervical cerclage for all in twin pregnancy or not. Why there is the need for debate? Because I think everybody here, whoever are here today in the morning session, must agree that when a twin pregnancy comes to us, the first thing that comes in our mind is she will end up in a preterm labor. So what should we do next? We give all type of gels, progesterone gel, high vaginal swab culture, urine culture, all the methods we use so that she goes up to term, so that the neonatal morbidity is less and everything else. But we do know that when a twin pregnancy comes, the rate of preterm birth is approximately 50% in less than 37 weeks of gestation, 14% in less than 33 weeks, and in less than 32 weeks of gestation, it is 8 times higher than that of those of singleton. That is why the need for debate is there. So what does the cervical cerclage do? It basically involves placing a stitch around the cervix so as it reinforces the cervix, and we know the strength of the cervix is increased. But whether we should go for it or not is a thing that we need to discuss. The arguments that are in favor is, as there is increased risk of preterm because uterine distension is more, so potential cause of cervical insufficiency will be there. So cervical cerclage may help mitigate this risk. And also, it is a must. We all know that patients with a history of cervical insufficiency, whether it is associated with whether previous preterm birth or second trimester pregnancy loss, are also strong candidates for cervical cerclage. But as I was talking about, why the need for debate? We know that vaginal progesterone decreases the preterm birth, but the studies have shown that in vaginal progesterone does not decrease the preterm birth in case of twin pregnancy. So basically we are using it just for our own satisfaction, not for the benefit of the patient. Somehow it may increase, but the studies are not showing as such. So why we are so focused? Because the ACOG guidelines in 2014 clearly stated that cervical cerclage may increase the risk of preterm birth when the cervical length is measured by vaginal ultrasound examination is less than 25 millimeter. This they told that it is not needed in cases of twin pregnancy if the cervical length is less than 25 millimeter. But these studies was further refuted later on, various studies which showed that cervical cerclage does decrease the rate of preterm birth when the cervical length is less than 15 millimeter or the cervix is dilated more than 10 millimeter. So the basis on which we are always telling that we shouldn't do cervical cerclage because the ACOG guidelines tell this, it is not true, because various studies later on which have come is showing something else. Here also the studies by C. Houlihan and et al. In 2016 further showed that cervical cerclage for preterm birth do help in prevention of twin gestation with short cervix. And here in this study, this was done on all twin pregnancies by Mama Sitter. In this, prophylactic cervical cerclage was done to all, and the mean gestational age at delivery was 35 plus minus 4 weeks, which is, I think, pretty good for a twin pregnancy. And in earlier also the study, Clarity study was also showed that the incidence of preterm birth with less than 35 weeks of gestation is decreased in the cerclage group compared with the non-cerclage group. Even the 11 et al. Study showed rescue cervical cerclage can effectively prolong gestational age at delivery. So why should we wait for rescue, or why should we wait for the cervical length to decrease? In cases of, suppose it is a Mullerian anomaly like unicornate uterus, bicornate uterus, there, irrespective of the size of the cervical length, we are doing a cervical encirclage because we know the rate of preterm birth is more in those cases. So why not in twin pregnancy? Why we have to say that when we know it is 8 times higher, the risk of preterm birth is 8 times higher than the singleton pregnancy. So why shouldn't we go for cervical cerclage in all? That is what I want to say, because various studies later on regarding that cervical cerclage should not be done in less than 25 millimeters is not effective. So various studies have do come up, and I think further dedicated studies are needed. In large subgroup of patients need to be taken, but I think when the vaginal progesterone is not working, the next line of treatment is this only, that we can do a cervical cerclage. At least by some means we can prolong the pregnancy. Thank you. अब आप काम करते हैं.
Anuja, you can wait while Dr. Surichi will be speaking against the motion.
Very good morning to the respected dignitaries on the dais and off the dais. I'm Dr. Smriti Sparsh, fertility expert. I would like to quote Muhammad Javed Zarif, who says, "I have disagreements with some, more agreements with others, but that doesn't mean I cannot listen to those I disagree with." Every coin has two sides, and indeed it was a nice representation of one side by Anuja madam, but I put forward my thoughts very humbly, but in absolute disagreement. Moving ahead, the topic for today is cervical cerclage in all IVF conceived twin gestation, where three important points that need to be considered is, should all be used, should IVF be considered, and should twin gestation be all that specific that we overlook every other factor? Coming to the term all, now we all know that individualized care, personalized care has taken ahead of everything which is called generalized one blanket for all treatment. So I'm somebody who is in favor of giving individualized care which is more justifiable, and it seems to look more patient friendly, and healthcare penetration where even government is taking stringent rules, where so many medical colleges are coming up and specialists will be available all around, where we are trying to imbibe and we are trying to give the proper healthcare even in the rural setup. Should terms like all be used? Because in all we are taking everybody in totality, where we can look at an individual one on a time, since so many medical facility and health facilities are coming up openly. Second, we are trying to normalize the term IVF. We are telling everyone that IVF is a modality of treatment, and don't look at IVF as something where you are trying to segregate the whole lot into IVF and natural conception. Even there are studies that are quoting that IVF patients need to be taken care, especially till 8 to 9 weeks, but after that you can even start taking care of an IVF patient like any other normal patient once the luteal placental shift has taken place. Thirdly, in twin gestation, there are many other causes that can lead to preterm labor. Sole reason, segregating twin gestation as a sole reason and trying to give cerclage to all the patient, is it really justifiable? There are many studies that are now telling that twin gestation cannot be taken up as the sole reason. In the presentation that we just saw, we saw that there are multiple research papers that have been put. Research papers are ideally published in a specific center with limited database that can be given. But RCOG guideline, the NICE guideline, the ASRM guidelines are what we think are the principles that help us formulate a thought process, where RCOG very clearly, I would like to quote, mentions that history indicated at least 3 preterm birth or second trimester loss is when we should think of cervical cerclage. But in the topic it says for all IVF conceived twin gestation, where I think to all the respected doctors present here, that let us be more judicious when we are selecting our patients, because cerclage is not a treatment that is not going to expose the patient to any risk. It is going to expose the patient to risk where you are not guaranteeing 100% prevention of preterm labor. So really, do we need to consider just by looking at the term twin gestation? Second, that USG guided cerclage is not recommended for multiple pregnancy. Again, I'm quoting the RCOG recommendation. And twin pregnancy alone is not a sole indication of cerclage. these were the RCOG guideline, but NICE also in 2022 says that good evidence with vaginal progesterone reduce the risk of preterm birth less than 34 weeks and in women with short cervix. So progesterone should be offered as an equal option. So another point where I would want to mention is that whenever we are taking care of the patient, and now when we have specialized our, there are super specialties available, when the health setups have become so vast and we can give and devote our time to history taking and physical examination. I think just by providing cervical circulage would not be an optimal modality to the patient or more convincing to the patient, saying that it is going to prevent preterm labor. So my humble submission here today would be that whenever we are thinking that we are performing a modality or trying to convince our patient, I think there has to be bigger studies, there have to be more recommendation from the guidelines that we follow, rather than just taking any modality as a blanket treatment and trying to convince the population, because we have teaching facilities and we have teachers here. So what we have learnt is that cervical cerclage is now an old process, and we are going from even invasive to minimum invasive and minimal invasive to less invasive. So resting my talk here, I would always somebody stand in favor of less is always better than more. So going for non-invasive modalities where there are so many talks and researches happening, where use of progesterone, pessaries are being promoted, and all the doctors sitting here, if you have seen an IVF prescription, I'm sure you must be thinking that we load a patient with progesterone. So when we are giving progesterone, why not move and try to convince the population where less is better than more? Closing with the Halton ARP lines, if one ignores contradictory observation, one can claim to have an elegant, robust theory, but certainly it isn't science. With this, I rest my talk. Thank you.
You would like to counter the against motion?
In IVF pregnancies, we cannot wait for 3 preterm births before we apply a cerclage. Because in IVF pregnancies, what happened, that they have come to us after a lot of time. It is not easy for us, for them to get a preterm birth. Because if they lose the baby, they don't have the guts to again go for an IVF, which is a long, not only a financial burden to them, but is an emotional burden also. And many of the patients are high-risk patients. They are coming at the age of 35, 40, 45 years. So in those cases, I think it is a better. And also in IVF with twins, as I have said, that it is 8 times higher. Even not IVF, it's a normal pregnancy also. If 8 times higher chances of preterm labor is there, then, and if the progesterone, if the studies are showing that the progesterone is not playing much role in preventing preterm birth in twins, many papers are there which are supporting that. So why not go for a cervical cerclage as we do it in a unicornate uterus, where we don't think twice before applying a cervical cerclage in those patients.
Thank you, ma'am. But again, I would want to put my thoughts here that there are absolute indications, contraindications, and there are certain midline thoughts also available, where I would like to quote from Madam's talk also, that many other indications from preterm labor exist, which could be maternal infection, the maternal causes like high BP and diabetes patients, anemia, and here in our status, I think we see more of anemia patients and a poor socioeconomic status patient where poor antenatal follow-ups are happening. It is quite possible that the patient is going into preterm labor because of many other causes than being sole reason of twin gestation. Second point is uterine distension. Also, madam has mentioned that uterine distension is there, so it can lead to preterm labor. No, most definitely uterine distension, but the other causes that we need to consider is, has polyhydramnios been used, and has polyhydramnios been diagnosed, high BP. There are other causes also, maternal obesity. We need to look at the weight gain that has happened during the labor. And then there is NICE guideline that I was quoting, which is the revised guideline of 2022, which says progesterone should be given an
I
equal
think
option.
we will have
Thank
to
you so much.
continue this because otherwise option nahi aayega. Yeah.
So both have put very good facts, and both the brilliant speakers have put their side brilliantly. And definitely progesterone is a non-invasive method, and the cerclage, we have to do surgery a little bit. So both are important, and IVF pregnancy is definitely very precious pregnancy. So to save the fetus, if indicated according to ultrasound measurement of cervix, I think cervical cerclage is indicated if the cervical length is less than 15 mm or there is a history of repeated preterm birth or abortion. And I would like Dr. Monica to say something.
Yes, ma'am, but quickly.
Yes, 30 seconds. So both of you have put your points very nicely. Excellent talks by both of you, putting up evidences to show that why it is important and why it is not. But definitely one thing always comes to our mind, that nothing can be a blanket treatment for everybody. So case based, depending on the case, how high the risk is, whether it is associated with other factors or not, definitely then a surgery will be beneficial, but something for all may not be beneficial. So thanks a lot.
Thank
It was a brilliant.
डॉक्टर नीलू आपका टॉक है, नहीं तो मैं उसमें से टाइम काटूंगा. आई लव यू टू मच मैम. चलेगा.
Just my suggestion, as I am looking after this class is really important, and 70 to 80% definitely the twin pregnancy or triple pregnancy land up into the preterm labor. So if I don't do this, I definitely repent after the situation that.
Thank you so much. With that, we come to the end of the. And we're going to continue this during lunchtime. So I would request all of them to please be here during lunch. Can I request our chairpersons to please join us? We have Dr. Neelam Manav, Dr. Vijaya, Dr. Pushpa Prakash, and Dr. Manjari. To save time, can I also request our speaker, Dr. Varsha Sinha, to please join us on the stage? Dr. Varsha Sinha, again, as you can see the CVs on the screen, the chairpersons are not requested to introduce the chairperson. Sorry, the speaker. The speaker gets total 8 minutes. I would believe it's time that madam gets started. Apologies for any disrespect, but
Good
ma'am,
morning, chairpersons
yes.
and dignitaries of the dais. I'm here to speak on antiphospholipid antibody positive, improving maternal and fetal prognosis.
Correct. He's going.
Okay. Take it. Thank you. A little bit about the history of the APS. We see false positive tests which was noted for the syphilis patient who did not have the infection, and antiphospholipid antibodies were first noted. Then it was noticed in some of these individuals developed SLE and other rheumatic conditions. Looking into the epidemiology, 1 to 5% of healthy individuals have APL antibodies, and the incidence is about 5 cases per 100,000 persons per year. 50% of the APS cases are not associated with other rheumatic disease, and APL antibodies were found in about 30 to 40% of patients with SLE, and only about 10% have APS. APL antibodies occur in 6% of the pregnant women without diagnosed APS and are related to many pregnancy complications. The antiphospholipid syndrome, that is the Hughes syndrome, is a systemic autoimmune disease with the specific and persistent circulating antiphospholipid antibodies leading to pregnancy complications and recurrent thrombosis. We take into account 3 antiphospholipid antibodies. They are anti-cardiolipin antibodies, anti-beta-2 glycoprotein 1, and lupus anticoagulant. So presence of antiphospholipid antibodies, thrombosis and or pregnancy complications, increased risk of thrombosis, preterm delivery, and fetal loss. The 10-year survival rate for APS patients is about 90.7%, with severe thrombosis as the leading cause of death, and 15.5% of women with APS became pregnant. 72.9% pregnancies resulted in live births. Early fetal loss is the most common obstetric complication of APS. We have 2 types, primary and the secondary, to other diseases. So in connection with the obs and gynae APLA, we have APLA and infertility, more common in infertile women and may affect embryo implantation, ovarian reserve, oocyte development, and they cause placental ischemia. Over 50% of APS women may have decreased ovarian reserve. IVF ICSI in APLA positive women results in increased miscarriage rates but comparable live birth rates. Common in APLA positive women, especially with positive anti-CL immunoglobulins. So we have APLA in APS and non-APS conditions. In infertility, as I said, impairs the embryo implantation, decreases ovarian reserve, and other factors. In pregnancy, we have a high-risk profile and a low-risk profile. So we have a classification criteria for APS. The clinical criteria consists of the vascular thrombosis, and we have the pregnancy complications. So one or more clinical episodes of arterial, venous, or small vessel thrombosis in any tissue or organ. Thrombosis must be confirmed by appropriate imaging studies or histopath. Thrombosis should be present without significant evidence of inflammation in the vessel wall. Regarding pregnancy morbidity, one or more unexplained deaths of a morphologically normal fetus at or beyond the 10th week of gestation with normal fetal morphology documented by ultrasound or by direct examination of the fetus. One or more premature births of a morphologically normal neonate before 34 weeks of gestation due to eclampsia, severe preeclampsia, or recognized features of placental insufficiency. 3 or more unexplained consecutive spontaneous abortions before the 10th week of gestation with maternal, anatomical, or hormonal abnormalities and paternal and maternal chromosomal causes excluded. So we have a lab criteria which consists of the lupus anticoagulant, anti-cardiolipin antibody, and anti-beta-2 glycoprotein antibody. So in these cases, in all the 3 cases, in the plasma, one on more than 2 occasions, at least 12 weeks apart, detected according to the guidelines of ISTH. Then we need to estimate the risks before pregnancy. Lupus anticoagulant is the strongest predictor of both pregnancy loss and thrombosis in APS patients. The specificity, isotype, titer, and the presence of multiple APL, LA, ACL, and anti-beta-2 glycoprotein influence the risk of thrombotic and obstetric APS manifestations. So triple positivity represents the highest risk profile. High-risk APL profiles are significantly associated with increased maternal vascular thrombosis, preeclampsia, APS-related pregnancy morbidity like IUGR, and preterm birth. So we have a lot of clinical manifestations. I'm not going into details of it. So we have to risk the estimation before pregnancy. Anti-beta-2 glycoprotein domain 1 antibodies, these are highly pathogenic and linked to both thrombotic risk and pregnancy complications, especially in late pregnancy. Ethnicity, SLE diagnosis, history of thrombosis or adverse pregnancy outcomes, and low complement levels during the first trimester further heighten the risk of pregnancy morbidity in APS patients. So here we link the APL antibodies and we see the inhibition of anticoagulant mechanism, direct cellular interaction, hypofibrinolytic condition, and complement activation. So there is netosis, the neutrophil apoptosis, and extracellular vesicles in the obstetrical APS pathogenesis. We have a Sydney criteria for APS that also reflects the same with regarding the pregnancy morbidity. Then how do we manage the obstetric APS? Women with APS or SLE who are APL positive should undergo preconceptional counseling to assess individual risk factors, including their APL profile. Management strategies should be personalized to optimize outcomes considering maternal and fetal status. Frequency and mode of monitoring should be adjusted according to the patient's risk profile and evolving clinical condition. So there are other major risk factors which are associated, like personal history of thrombosis, thrombophilia, SLE, APS, heart disease, obesity, diabetes, smoking, sickle cell disease, and many more. So how do we manage APLA pregnancies? Antepartum, unclear risk, study find, then we have to decide, should be based on the patient gynecologist discussions with individual risk-benefit assessment. During the postpartum period, so this is based basically on the prophylaxis. We have a lot of guidelines, ACCP guidelines, Korean guidelines, and then we need to prophylaxis. We go for prophylaxis, intermittent pneumatic compression in the hospital, compression stockings post-discharge, and low-dose aspirin for 6 weeks after vaginal delivery, or low molecular weight heparin, and low-dose aspirin for 6 weeks after cesarean. So in obstetric APS, if there is no history of thrombosis, then thromboprophylaxis is not recommended. LDA is considered, low dose aspirin. Pregnancy planning management differs from attempting pregnancy. In antepartum period, during the preconception, low dose aspirin, pregnancy counseling, and the management is based on the morbidities like recurrent fetal loss, early preterm birth, and LDA plus low molecule. Just 1 minute. Now the general rule applies that treatment regimens for APS must be according to the patient's clinical condition and history of thrombotic events. In asymptomatic individuals, no specific treatment, but prophylactic treatment, elimination of the risk factors and the other factors which are taken into account. Prophylaxis is needed during surgery or hospitalization as well as any other associated autoimmune disease. Low dose aspirin is widely used in prophylaxis. In patients with SLE, we should consider hydroxychloroquine along with that. In thrombosis, full anticoagulation, IV or subcutaneous heparin followed by warfarin therapy. Our target for INR 2 to 3 for venous thrombosis, 3 for arterial thrombosis, and patients with recurrent thrombotic events may require INR of 3 to 4. Okay. Severe refractory cases, warfarin or aspirin may be used. So rituximab, this also can be considered for recurrent thrombosis. And let me come up because we have a lot of things. I know this. Conclusion, I want to highlight. In management of obstetric APLS with recurrent abortion, if pregnancy is attempted till the conception is confirmed, low dose aspirin should be given, and from the conception confirmed till delivery, low dose aspirin with low molecular weight heparin, and postpartum low dose aspirin and low molecular weight heparin is considered. Then we talk about in recurrent abortion, if warfarin was instituted earlier, pregnancy attempted till conception, warfarin, low dose aspirin, low molecular weight heparin, till delivery, and later warfarin. So we have a lot of managements, but this is a guideline for investigation and management to antiphospholipid syndrome 2024, prednisolone, IV immunoglobulin, hydroxychloroquine treatment in women with obstetric complications, despite aspirin and low molecular weight heparin are suggested only on a case-based basis. Women with APS who are breastfeeding and require anticoagulation should remain on either low molecular weight heparin or warfarin. So to conclude, primary prevention is not recommended for asymptomatic APL positive women, anticoagulation consideration in high risk conditions. Low dose aspirin is recommended before conception and during pregnancy to improve outcomes. Postpartum care is must, 6 weeks. Low dose aspirin for vaginal delivery, low dose aspirin, low molecular weight heparin for 6 weeks after cesarean because it poses more thrombotic events. Obstetric APS, LDA before pregnancy, LDA and low molecular weight heparin during pregnancy and 6 weeks postpartum. Premature birth in uteroplacental insufficiency, LDA alone is acceptable. Vascular APS, warfarin until pregnancy confirmed. Treatment decisions based on prior obstetric vascular complications and traditional thrombosis risk factors, and there are limitations. So our approach should be tailored, patient-oriented, and treatment is crucial. Thank you so much.
Thank you so much. I'm sorry, ma'am, but questions are to be taken during tea time. I totally understand. Otherwise, yes, tea time is definitely there, and there's very good tutti frutti cake also with that. Thank you so much. Can I request Dr. Richa Jha, ma'am, to please join us on the stage? रिचा का प्रेजेंटेशन डाल दो जल्दी स्क्रीन पर. Dr. Richa has also asked me थोड़ा सा 10 मिनट दे दो. मैंने बोला कैसे दे. Please, you can start.
Okay, so a very good morning to the respected chairpersons and all the august gathering present in the hall. I am going to talk about a very important yet a rare complication during pregnancy, that is dengue infection in pregnancy. So just to introduce the topic, it is one of the most rapidly spreading mosquito-borne viral diseases. Two major vectors are there, Aedes aegypti and Aedes albopictus. It has been identified as one of the 17 neglected tropical diseases as submitted by the WHO in their report. It belongs to Flaviviridae family. 4 serotypes are there, dengue 1 to dengue 4, and all these keep circulating one by one. So the primary infection is usually not of that much severity, but if the person gets infected with another serotype subsequently, then the the immune response is mounted and it leads to a severe infection. Now coming to the magnitude of the problem, since the population density is mostly concentrated in the tropical regions, so 40% of the world population is estimated to live in a dengue endemic zone. It has shown uprise because of poor urbanization, because of poor water management, etc., etc. And WHO estimates around 22,000 deaths occurring annually because of dengue. It is the cause of 7.1% of the febrile illnesses during pregnancy. But the good thing is that early detection and proper medical care can bring down the case fatality rate to less than 1%. It is a notifiable disease and hence all cases should be reported. Now in our part of the world where we get seasons, it typically shows a trend or an upward trend post monsoon, but in such in the south down where the seasonal variations are not there, it shows a perennial trend. Now as we can see that pregnancy is associated with the severity of the disease. And coming to the pathophysiology, two main things that I want to point out is that there is T cell activation, and second, there is antibody dependent enhancement. So both of these phenomena, they basically lead to vasculopathy, coagulopathy, cytopathy, and if not managed properly, can lead to organopathy, which is very, very serious. Now, initially, we used to study about dengue, dengue fever, dengue hemorrhagic fever, and dengue shock syndrome. So, all these terminologies have been done away with, and 2019, WHO classifies dengue as having without warning signs, with warning signs, which are abdominal pain, clinical finding of fluid accumulation like ascites, mucosal bleed, hepatomegaly, etc., and severe dengue, where there is multiple organ involvement. Then it typically shows a triphasic course. That is, first there is the febrile illness lasting for 1 to 4 days, where we typically get a low WBC count and dehydration is one of the complications. Critical phase, where patient starts leaking and there is shock, bleeding, multiple organ involvement, platelet count falls down and hematocrit starts rising. And then the recovery phase, where there is a complication of volume overload. Now this is the same thing that has been shown. The tunicate test that was done initially as a bedside test for early detection of dengue is no longer used now, and it is of less clinical importance. One thing I would like to say that NS1 antigen, don't be in a very rush to prescribe NS1 antigen when a patient with fever comes to you, because it comes positive only by day 3, IgM antibody by day 5, and IgG by day 7 onwards. Now this is the proper case definition of dengue as prescribed by the Ministry of Health and Family Welfare, India. Now, there are certain challenges about recognition of dengue in pregnancy. Why? Because, firstly, vomiting, which was seen as one of the warning signs of dengue, it may be mistaken as hyperemesis of pregnancy. Secondly, already there is baseline tachycardia. But a word of caution over here, whenever you get a heart rate of more than 100, it always needs evaluation, and don't just disregard it as having a baseline tachycardia which is present in the pregnancy. Now, postural hypotension, which is suggestive of volume depletion, it may be misinterpreted as supine hypotension of pregnancy. Fourth, because of physiological hemodilution during pregnancy, hemoconcentration with plasma leakage, which is a hallmark of dengue infection, it may be masked. Then already during pregnancy, the pulmonary capillary wedge pressure gradient is reduced. So this finding pushes these patients of dengue hemorrhagic fever into early development of pulmonary edema, especially during the convalescent phase. Then, because of the growing uterine size, there is failure to recognize plasma leakage and ascites. Because of physiological leukocytosis in pregnancy, the febrile leukopenia, which during the febrile phase, the leukopenia, which is one of the hallmark of the initial febrile phase, it may not be that much evident. Then again, during pregnancy, there is already gestational thrombocytopenia. But again, a word of caution here, if we get a platelet count of less than 80,000, please don't just disregard it as having a gestational thrombocytopenia. It needs a thorough evaluation. Then pregnancy itself is a procoagulable state. Hence, pregnant women with dengue hemorrhagic fever are more likely to develop consumptive coagulopathy. And there could be delayed diagnosis because of the overlapping clinical or lab features with better recognized conditions of pregnancy like HELP. So if a patient with comes to us with a low platelet count and an elevated liver enzymes, the first thing that comes to our mind is obviously HELP, and no one is going to think of dengue. But then there is a word of caution here where we need to evaluate a proper history and take the history of fever, having fever 3 to 4 days prior to the development of all these features. Now, these are two very important articles that have been published, and they have studied the impact of dengue, especially in the Southeast Asian population, and they have shown that these are the things that can happen during pregnancy on the mother. That is, abortion, increased risk of preeclampsia, preterm labor, increased risk of fetal growth restriction, abruptio, increased incidence of stillbirth, and higher cesarean delivery rates because of fetal distress. Then again, because of high incidence of PPH, which is very much understandable, fulminant hepatic failure, expanded dengue syndrome, DIC, and maternal mortality if not taken care of properly. Then does it have an impact on the fetus? Yes, obviously, because vertical transmission has been reported in about 18.5 to 22.7% of the cases, the risk being highest in the third trimester. Then clinical presentations, it might range from a simple fever to rash to dengue shock syndrome, but again, we have to understand that there is insufficient data to prove that there is any risk of embryopathy, and hence it does not warrant termination of pregnancy. Then again, there could be neurodevelopmental delays and prematurity and low birth weight babies. So this is how we can differentiate between dengue hemorrhagic fever and HELLP syndrome. The main thing that we have to understand here, that if we get a patient of HELLP, the management would be termination of pregnancy at the earliest, and in cases of dengue hemorrhagic fever, we need to delay the delivery until the critical phase. Now coming to management of dengue in pregnancy, it is no different than management in the normal population. All the patients, but here we have to understand that all the pregnant patients, since they belong to a high risk category, they need admission for close monitoring. We have to be very, very vigilant. We have to do a baseline CBC on day 1 or day 2 of fever. If WBC is on a lower side, then obviously we need to repeat it after 24 hours and compare a further fall. Then we have to do a capillary refill time, which is a very good test done bedside. If it is more than 2 seconds, then obviously it might suggest towards a volume depletion, and we have to be very careful in monitoring the input-output charting. Then these are the investigations that we have to do. Ultrasound, not only for fetal well-being and AFI with color Doppler, but also to look for fluid accumulation in the abdominal cavity. And all these investigations can be done at a later stage as depending on the case. Now coming to the treatment, if it is without warning signs, that if it is a simple dengue fever, then you have to admit the patient and provide adequate nursing care. PCM has to be given only. We have to avoid NSAIDs as has been the standard teaching. We have to withhold aspirin if the patient is already taking, and ensure an oral intake of at least 2.5 to 3 liters of fluids. Now if the patient is having severe nausea and vomiting, we have to give IV fluids. But if she develops any of these warning signs, then IV fluids have to be started at the earliest. Now, which choice? The choice of IV fluids, always use isotonic isoosmolar solutions like normal saline or Ringer's lactate, and avoid hypotonic solutions and dextrose containing solutions. Now with warning signs, as I've already said, intense fluid resuscitation has to be started. We give a bolus of 7 to 10 ml per kg per hour for 2 hours, followed by 3 to 5 ml per kg per hour as maintenance. Now these are the parameters that have to be monitored, and when we are de-escalating, we have to be very, very careful, because we do not rapidly de-escalate the dose. It has to be a gradual de-escalation of the IV fluids. If there is no clinical improvement, then again a second bolus has to be given, and if there is if the hematocrit falls drastically, we have to suspect overt bleed and give IV transfusion. So I'm not going into the details of the medical management. If the patient presents in shock, she has to be managed in ICCU. Now coming to, if there is inevitable...
You can help us on the conclusion slide,
Yeah,
please.
yeah, just 1 minute. If there is inevitable delivery during the critical phase, just remember that delivery should take place in the hospital where blood products are available. Anticipate bleeding, avoid trauma, don't give methergin, quantify PPH, and inform neonatologist well in advance. Transfusion trigger is low in cases of dengue than other indications of BT. And coming to the role of platelet transfusion, just keep in mind that only having a low platelet count is not an indication for prophylactic platelet transfusion, as there is no relationship with bleeding and a low platelet count. But if the vaginal delivery is inevitable, or if we are anticipating in 6 hours, then only we have to give platelets. There is no role of steroids, no role of prophylactic antibiotics, no role of IV immunoglobulins, and tocolysis as it was earlier indicated, but now there is lack of evidence to suggest tocolysis.
Apologies, but yeah, we'll have to
so
go to the
during the
conclusion.
convalescence phase, just 1 minute, we have to be very, very cautious.
Stop, yeah.
Okay.
Please, on the slide. Yes, thank you.
Okay, so this is to summarize my talk. During the convalescence phase, we just need to add another word of caution, that we have to be careful for volume overload. And to summarize, I would like to say that physiological changes during pregnancy mimic the warning signs of dengue, and hence early recognition becomes a challenge. The common complications, as I already said, there is no role for prophylactic platelet transfusion, and be very vigilant for development of dengue in the newborn also. We have to inform the neonatologist well in advance. So just to conclude, I would like to say that before we get a safe and a dengue vaccine is available for the use in the general population, we just need to be careful and remember that still waters breed death. So we need to stop dengue infection during pregnancy. Thank you.
The next we have Dr. Neelu Prasad. Thank you. And Dr. Neelu का time start कर दे. वो पहले वो बोल रही थी ना. हाँ. Start. Yes.
A very good morning to one and all present here, respected chairperson, all the dignitaries and the wise audience. And this is my privilege to be part of this conference and participating on this platform. So really this is the platform where we can exchange our knowledge, share our ideas and inspire each other. Now without delay, I am going to start my topic. My topic is tuberculosis in pregnancy. Tuberculosis is such a vast topic, so it is very difficult to finish in a 10 minutes time in presence of this Nikhil team. So without delay, I am going to start tuberculosis in pregnancy. Sorry. So everyone know about the definition regarding the tuberculosis is a contagious bacterial infection and caused by the acid-fast bacilli and known as the Mycobacterium tuberculosis. And it primarily affects the lungs, can also impact the other parts of the body, and that is characterized by the low-grade fever, loss of weight and chronic cough. The word tuberculosis comes from a Latin word for nodules, and for some time that stick out. The bacteria gets into the lung through the inhaled air contaminated by the sputum positive cases. If we talk about the incidence ranges between the 1 to 2% among the hospital delivery. Although it is an iceberg, only we have the data that present to our hospital. In fact, in 1993, WHO pronounced tuberculosis as an global health emergency. Tuberculosis cases 2.3 million and were estimated to have occurred in the India and accounts for the 30% of the burden of all tuberculosis cases in the world. Lung is the major site for the involvement, but the lymph node, meninges, bone, joint, intestine, and the kidney are also be affected. In India, 2 deaths every 3 minutes are recorded, and this is the almost 1,000 deaths per day by tuberculosis. These are the clinical features. The symptoms of the tuberculosis in the pregnant women can be non-specific. Everyone not present by the same symptoms, some having the loss of appetite, pale coloration, ill looking, low-grade fever, fatigue, malaise, chronic cough, hemoptysis, chest pain, and shortness of breath, and the night sweating and the loss of weight. So diagnostic evaluation is very important, and simply by the positive family history, their locality and family history, the suffering from the tuberculosis. Another is the clinical features. These are all the supportive investigation aids. X-ray examination is also very important, but in pregnancy, in the early pregnancy, X-ray is not indicated. Another test is the sputum examination for the AFP and diagnostic bronchoscopy. Diagnosis of the extrapulmonary tuberculosis is done by the histopathology and FNAC depending upon the site of the involvement. So now, what are the effects of the tuberculosis in pregnancy? That my topic is. If the mother is suffering from the tuberculosis, the pregnant women with untreated tuberculosis are more likely to have preeclampsia, spontaneous abortion, preterm labor, difficult labor, and PPH. Intrauterine fetal death is also recorded. Anemia is also very common because in that cases the immunity is depressed, their nutritional deficiency is associated together. If the diagnosis is delayed, morbidity increases to 4 folds. The effect on the developing fetus
is also there. There is IUGR, preterm labor, low Apgar score of the baby, low birth weight, and perinatal death is also recorded. Now come to the treatment point. The treatment for the drug-sensitive tuberculosis. During the pregnancy, the treatment for the drug-sensitive tuberculosis during pregnancy involved standard for the 6-month regime. Initially, the first intensive phase for the 2 months, and that included 4 drugs: INH, rifampicin, ethambutol, and parazinamide, and the continuous 4 months therapy by the INH and the rifampicin. The safety consideration is that parazinamide, although it is not universally recommended, but the WHO recommendation consider it is safe in pregnancy. And streptomycin is totally avoided in the pregnancy because it causes congenital deafness of the baby. So these are the drugs and their doses and the major side effects. So INH having hepatitis, peripheral neuropathy, hypersensitivity. Rifampicin having the nausea, vomiting, hepatitis, orange discoloration of the urine, and other secretions, and the febrile reactions. Ethambutol, they cause skin rashes, optic neuritis, decreased vascular activity. And the parazinamide, they cause hepatotoxicity, skin rashes, arthralgia, and hyperuricemia and GI side effects. So after delivery, care has to be taken of the baby as well as the mother also. The decision to treat the tuberculosis in the pregnancy must consider the potential risk and benefit to the mother and the fetus from medication. If the mother is non-infectious, she can handle her baby. And ordinarily, BCG vaccination is given to protect the baby. Breastfeeding is not contraindicated when the woman is taking anti-tuberculous drug. But in active cases, breastfeeding is contraindicated and baby is isolated from the mother following delivery. Baby should be given prophylactic INH 10 to 20 milligram per kilogram per day for the 3 months when the mother is suffering from active diseases. Now come to the conclusion. Diagnosis and the treatment of the tuberculosis during the pregnancy is a real challenge. Pregnancy and the tuberculosis require careful management to ensure favorable outcome of both mother and the baby. Early diagnosis, appropriate treatment, and close monitoring by healthcare professionals are critical. So pregnancy is not a contraindication for the treatment of tuberculosis. Good quality treatment is prerequisite for the prevention of the emergence of drug resistance. Special precautions are essential in extrapulmonary, recurrent, and other type of tuberculosis. Proper counseling, supervision, and reassurance play a key role in the success of treatment. With timely care, most women with the tuberculosis can have safe pregnancy and deliver healthy baby. Thank you. Thank you for your understanding.
Thank you, Neelu. Thank you, Neelu. You well described about tuberculosis in pregnancy.
And
very nice, and your fixed time also.
40 seconds before time, I would say.
Yes.
Yeah. I think I would give a big round of applause to madam. Thank you so much. Thank you.
Thank you everyone.
Thank you, ma'am. You have nicely presented this topic. Thanks a lot.
Can I request now the speakers and the chairpersons to please join us next to the backdrop where we would present you with a memento and take a picture as well. Photographer, chai baad mein peena, chalo. Can I request the chairpersons for the next session to please... नहीं यहाँ पर आपके फोटो बहुत काले आ रहे हैं मैडम, बहुत इसीलिए नहीं आ रहे मैडम, सच में मैं आपको बता रहा हूँ लंच टाइम में, नहीं तो मैं स्क्रीन बंद करके करवा दूँगा, लंच टाइम पे मैं स्क्रीन बंद करके कर सकता हूँ। ले ले भाई एक फोटो इधर ले ले, बाद में मैडम को दिखा देना कैसे आ रहा है। 3, 2, 1 जैसा भी ले ले। Can I request the chairperson for the next to please join us? We have Dr. Neelam and Dr. Supriya Jaiswal. We've also got a rock star who's going to be the speaker. We've got Dr. Sampath Kumari, ma'am. As you can see, Dr. Sampath Kumari ma'am is Foxy Vice President 2023, Vice President OGSSI. She doesn't need any more introduction. You can read it right onto the screen. And she also likes to keep it on time. I'm sure about that.
Otherwise, Nikhil will.
Thank you.
No, I won't.
Thank you, organizers, for giving us this opportunity to share such an important session in which we are going to listen Dr. Sampath Kumari on managing HELP syndrome.
Thank you. Thanks to the chairperson and thanks to Dr. Meena and Dr. Vinita who called me for this wonderful conference, the annual conference of Patna. See, the topic is HELP. See, what do you know? This HELP, all of us would have seen at least one case in our experience. This is the hemolysis, elevated liver enzyme, low platelets. And this condition occurs during the late stage of pregnancy and after the childbirth. It is named by Dr. Louis Winston in 1982. See, what is the pathology of this HELP syndrome? This is the hepatic endothelial disruption followed by platelet activation, aggregation, and consumption, ultimately leading to the hepatocyte death. What happens with this? This is the periportal and focal parenchymal necrosis and obstruction to the hepatic blood flow. Always we know that hypertensive disorder in pregnancy, there is a vasoconstriction. The main cause is the placenta. So what happens when there is the vasoconstrictions to the hepatic blood flow? Periportal necrosis, intrahepatic hemorrhage, subcapsular hematoma, and Glissen's capsule rupture, which leads to the HELP syndrome. So whenever a patient on treatment,
can we have some silence please from the picture taking group?
Hypertensive disorder in pregnancy, if the patient complains of upper epigastric pain, we have to think of HELP syndrome. See, this hypertensive disorder in pregnancy, when it is before 20 weeks, we call them as chronic hypertension. When it is after 20 weeks with 2 readings of 6 hours apart, it can be a gestational hypertension, and if it is associated with proteinuria, it is preeclampsia. Preeclampsia can be late onset and early onset, and it can be severe and it can be mild. If it is a severe preeclampsia, it can go for HELP syndrome. So the chronic hypertension can be superimposed with preeclampsia and eclampsia. This is the simple classification of hypertensive disorder. The prevalence of HELP, which is one of the complications can happen with severe preeclampsia, is 0.5 to 0.9%, and 70% occurs in the 3rd trimester and after delivery. The mortality with the HELP is 0 to 24%, and sometimes even up to 37% of the perinatal death. There are some classification, Mississippi classifications and Tennessee classification. This classification depends on the clinical signs and the laboratory findings. Normally we know that the liver enzymes all elevated and the platelets. Depending on the platelets, whether it is less than 50,000 or 50,000 to 1 lakh or more than 1 lakh. Depending on that, we classify as class 1, 2, 3. Depending on the platelets, prognosis will be bad. So the lab investigations that is needed is hemolysis, abnormal peripheral smear, LDH, bilirubin more than 1.2, and the liver enzymes all is elevated. That is lactate dehydrogenase more than 600, low platelets. The platelet is the main culprit which produces all the complications. This is the older classification which depends on the platelet count and the liver enzymes and the hemolysis on the peripheral smear. When there is this 3 findings, if any 2 or 3 is present, means it can be called as partial HELP. If all the 3 is present, it is called as HELP. These are all classifications when we were doing our PG. Now we don't have this type of classification depending on the platelets only 1, 2, 3. How can we know that the HELP is? If a patient on hypertension, even the BP is controlled. If patient comes with the complaints of upper epigastric pain, don't think that it will get resolved with antacids and do other investigations. If the patient on antihypertensive and if you have the diagnosis that she is a gestational hypertension, even if the BP is normal, if right upper epigastric pain is present, it can be the HELP. So as you are talking about the previous speaker, dengue, acute liver, fatty liver, all these symptoms are there. But if the hypertension is present, proteinuria was present, then you have to think of HELP only.
The other associated features can be jaundice, increased abdominal girth, swelling, headache, blurring of vision. These are all the symptoms of the imminent signs of the preeclampsia. So examination always, once you have diagnosed the patients are hypertensive disorder in pregnancy, BP monitoring is very, very important. Always in the second trimester, there will be a fall of BP, but that is the sign when the Doppler we have the diastolic notch. So the BP monitoring with appropriate cuff and appropriate procedure, left lateral position or sitting posture with all the levels, lower border of the heart and the BP apparatus and the patient, all should be in the straight line. So this monitoring is very, very important. If it is increased, the standard value is 140/90. Nowadays they tell even the 135 also. So the right upper quadrant pain and the icterus visual disturbance, pedal edema, if present, are associated with increased BP, then you have to think of the HELP syndrome. As I told, the investigation is already, if a patient is diagnosed to have hypertension, we will have the base readings of RFT, LFT, complete hemogram, fundus examinations and all the routine investigations for antenatal. But the special when we consider as HELP means complete blood count, peripheral smear, liver test again, creatinine, prothrombin time, PTTT and fibrinogen. If there is a disturbance, that from the baseline, what is the change and what is the level of the HELP has to be identified. The recurrence in future pregnancy is 16 to 52%. And the rate of recurrent HELP ranges from 2 to 19%. We do not know which patient will go for hypertensive disorder and which will go for preeclampsia. But since the risk factors we have to consider is over age 35, African American, obese, previous pregnancy, previous PIH, diabetes and history of preeclampsia. This patient we should be very careful and monitor the signs, monitor the BP. And always I used to tell my PGs to ask 4 questions. If the patient is increased BP, headache, not relieved by taking rest and analgesics, blurring of vision, upper epigastric pain, reduced urinary output, and finally the fetal movement. If any one is present, we can know that it will be a case of severe preeclampsia. The patient will never complain, will never tell the complaints. We have to put the leading question to prevent the complications and mortality. Still in maternal mortality, hypertensive disorder is one of the common cause for maternal mortality. Hypertensive and PPH. Nowadays PPH is also with all factor 8 and all the products, the PPH is also monitored. That BP alone, most of the VHN will tell, we are monitoring the BP, but patient came with the fits. So the routine BP monitoring is very, very important. Now we will come to the management. So the treatment of HELP syndrome, this is based on the gestational age, clinical condition and the lab findings. It can come even in 28 weeks, 32 weeks or 36 weeks. Depending on the gestational age, we are going to wonder whether we are going to save the mother or we are going to save the mother and the baby. That is very, very important. Best treatment is early identification. That is the best way to treat the HELP syndrome. That is monitor the BP and if any signs present, you think that it can be the HELP. So the management, if the patient is after 36 weeks, immediate delivery is better, not to go with any complications. Primary choice is after 36 weeks. If she is at 27 to 34 weeks also, always for HELP syndrome, immediate delivery is important. But if the patient is stable, if it is in 27 to 34 weeks, we can wait for 48 hours for the steroid effect. That can be better. And if the patient is not with a good Bishop score and if it is not in labor, it is better to go with the LSCS. The expected management for 48 to 72 hours, if the patient is stable and if she is after 27 weeks, you can think over. Otherwise, there is no possibility for expected management. Even if it is less than 24 weeks, we are going to deliver. How are we going to do? We are going to admit the patient, bed rest, blood transfusion, depending on the platelets and depending on the blood components. Whether we are going to give the platelets or PCV, whatever it is, it has to be given. And the magnesium sulfate. Magnesium sulfate is the life-saving drugs and it will prevent seizures and it will reduce the preeclampsia and it will prevent the complications of the end organ damage. Antihypertensive. The antihypertensive for hypertensive disorder in pregnancy is labetalol. Labetalol is the only treatment for hypertensive disorder in pregnancy. As all of us know, it can be 100 milligram tablet. Depending on the BP measurement, it can be given once and it can be given twice or it can be given thrice also. Labetalol is the golden standard treatment for the hypertensive disorder in pregnancy. If the BP is not controlled with the labetalol, then you can go with the nifedipine extra. If the BP is very severe, that is a very high, 200 by 160, there also we can go with the labetalol IV infusion. Even if the patient is not conscious, you can go with the BP is increased, labetalol infusion. Then depending on the gestational age, corticosteroid, lung maturity. So blood transfusion, magnesium sulfate, labetalol. Always call for help if whatever the complications. The fetal monitoring should be tested with the CTG and the fetal movement evaluation or continuous CTG monitoring if facilities are there. So labetalol, as I told, if it is not controlled, you can add with nifedipine. Nifedipine, the main complication is hypotension will be present. Methyl dopa, it is a long-acting action. So nowadays we don't use methyl dopa. In the postnatal period, you can use that. Labetalol, if the BP is more than 200 or severe preeclampsia, in that cases you can go with this IV infusion. You start with 20 milligram, monitor the BP after 10 minutes, increase the double the dose, 40 milligram, monitor the BP after 10 minutes, increase to 80 milligram. Like that up to 220 milligram, you can use the labetalol IV infusion. It is 4 ml, it is present. And once the BP is controlled, you can go with the oral labetalol tablet. The steroids, as all of us know, for the fetal lung maturity, it can be given betamethasone or dexamethasone 12 mg or 6 mg. Blood, if the platelet is less than 40,000, 6 to 10 units of blood transfusion should be given and it has to be monitored. This packed cell volume depending on the blood complete smear. And this antithrombin 3 transfusion, this is given. This is to correct the hypercoagulability and stimulates the protocyclin production and regulates thrombin-induced vasoconstriction and improves the fetal status. As all of us know, the vasoconstriction is the pathology and in the placenta the complication lies. So if you give the drugs to remove this vasoconstriction, complications will be reduced. Then the magnesium sulfate regimen. Whether it is the primary health center or whether it is a hospital where there is no facility, if the patient is having severe preeclampsia with the imminent sign, this magnesium sulfate pre-chart regimen should be given. The loading dose is 4 gram 20% and IV and 10 gram IM. Each ampule is 2 ml, each ampule is 1 gram. The available ampule is 50%. So to make to IV, you take 4 ampules in 20 ml syringe, dilute with 12 ml of normal saline and give IV within 5 to 10 minutes to change 50% to 20%. Then IM, each ampule is 1 gram, 2 ml. So 5 ampules in the right side upper gluteal region and the 5 ampules in the left side gluteal region. So 10 grams should be given each of 20 ml. If the patient is having pain means you can mix with 1 ml of lignocaine. So always keep 14 ampules of magnesium sulfate ready in the labor ward, antenatal ward and in the theatre. The maintenance dose, how are you going to continue this magnesium sulfate? Every 4 hours 5 gram IM. That is 5 ampules. At 4 o'clock if you are giving means at right side, at 8 o'clock left side, 12 o'clock right side. Alternatively for 24 hours after the last fit or after the delivery. So after in between these 4 hours, if the BP is, the things you have to monitor is respiratory rate, urinary output, patellar reflex. If anything is not there, suppose urinary output is only 40 ml, skip the 8 o'clock dose, but don't stop the magnesium sulfate regimen. It has to be continued for 24 hours. And at 12 o'clock dose, you have to do, and you have to maintain the magnesium sulfate chart. In the teaching institute, you also follow the Zussman regimen, where the magnesium sulfate is given in as infusion. The fluid management, always it is better in case of whatever in pregnancy itself, and that too in hypertensive disorder cases, 80 ml per hour. Mode of delivery, 34 weeks completed and the patient is stable, you can see the Bishop score and no induction, nothing, you have to do it immediate delivery. Otherwise, you can take for LSCS if it has to be delivered immediately. Previously, but now recommended that who are at least 34 weeks gestation and favorable cervix should be given trial of labor. That is not the immediate LSCS. If you are okay and if good monitoring is present for the mother and the baby and the ICU setup, you can go for the trial of labor, but otherwise don't waste the time, you can go for LSCS. These are all the other supports which we need in the ICU, ventilatory supports, vasopressor support, surgical interventions, if at all needed, invasive percutaneous embolization, this and all practically we are not doing, but for completions. So we have to correct the DIC, pulmonary edema, acute respiratory failure, and the kidney injury, which are all the associated complications. So the management of HELP syndrome, if it is less than 32 weeks, give corticosteroids, the same thing. If the patient is stable, and if you have the facility, and if you have hands-on anesthetist, pediatrician, ICU, everything, you can wait. Otherwise, you can deliver it immediately. 32 to 34 weeks, better you give the corticosteroids for the baby's sake. Everything is only for the baby's sake. As far as hypertensive is concerned, we are bothered about the mother, the mortality. So if it is less than 34 weeks, same things. Whatever the weeks, possible, wait for 48 to 72 hours. If everything is good, go for trial of labor. If not good, go for LSCS. The complications are eclampsia, cesarean section, recurrent thrombus, fulminant liver failure, cerebral hemorrhage, cardiovascular instability, infection, then the routine placental abruption, DIC, cerebral infarction, retinal detachment, and maternal death. The rupture, the subcapsular rupture is rare and it can occur in 1 in 40,000. This is common in the right lobe. Sudden onset of pain in the epigastric region and the right upper abdominal quadrant radiating to the back, shoulder, anemia, hypotension. Think of the rupture and do whatever is needed. These are all the complications of the baby: perinatal death, placental insufficiency IUGR, preterm birth, neonatal thrombocytopenia, and RDS. The differential diagnosis, already I have mentioned, that is acute fatty liver, TTP, pregnancy-related hyperuremic syndrome, SLE and other types of fever, APS and viral hepatitis. Atypical, this is if it is no symptoms, no BP, then also you can have this HELP that we have to monitor with the investigations. For all patients, if you suspect, do the liver RFT, LFT, fundal exam. Prevention, nothing can prevent preeclampsia, but still regular prenatal visits during pregnancy, and if the patient is a hypertensive disorder in pregnancy with two readings of more than 140 by 90 BP with 6 hours apart, ask the leading questions: headache, blurring of vision, upper epigastric pain, reduced urinary output, and fetal movement. You can pick up the severe signs of the preeclampsia and you can monitor the prevent the complications. So the warning signs: in the next pregnancy, aspirin can be given. This steroid treatment, previously it was thought that high dose steroids, but nowadays it is not useful. Only for the lung maturity we are giving these steroids. That high dose is 10 milligram intravenously every 12 hours. That's not needed nowadays because we are not going to wait. We are going to deliver the patient. Steroid is not a curative, but may create a window of opportunity for intervention before maternal conditions deteriorate. So our aim is to prevent the mortality. So conclusion is, monitor the BP regularly. Always I will tell, BP monitoring alone will reduce the complications. Early identifications of the imminent signs and symptoms, and refer the patient. Don't refer at the last minute. If the facility is not there, or if it is in the primary health center, refer to the higher institute where all the facilities are there with all the documentations. What is the loading dose given, what is the antihypertensive given, what are IV fluids, how much you have given, and what are all, whether you have given steroids. Monitor everything and refer the patient. If possible, give a call to the higher center that such a patient is coming. They will also be ready to reduce the mortality. Thank you. There is no end to learning, but there are many beginnings. Thank you.
Thank you, Dr. Sampath Kumari. It was a wonderful talk about HELP syndrome. It got revised and very comprehensive in very details. You touched every aspect, from diagnosis to management to prevention to treatment. Really, you're at the back of the mind when you have any patient with hypertension, you always keep it that she might go into it, and it is a dreaded disease.
Madam, it was a wonderful talk, and it is a nightmare for any obstetrician, the HELP syndrome that involves multi-organ. And then to stabilize is the first thing we should do. And rightly you said, if it is, she can come in pain, she can come with fits, and epigastric pain is really very, very yeah, challenging. You never know what is the real cause. So you have touched on so many things, and the quotes you put are wonderful. I usually read your quotes. Thank you very much, madam, for coming here. Thank you.
Thank you so much, and I would also like to thank Man for completing it on time as well. For the next, can I request our chairpersons to please join us? We have Dr. Prerna Kaul and Dr. Rashmi Agarwal. Our first speaker is Dr. Sarita.
Let us proceed with the prestigious UNICEF session on EPMM ENAP, Ending Preventable Mortality in Every Newborn Action Plan. In order to start the session, let me invite the esteemed chairperson, Dr. Rashmi Agarwal, Madam, MD Pediatrician, Associate Professor, NMCH Patna, Honorable Secretary, IAP Bihar. Welcome, ma'am. The other chairperson is Dr. Prerna Kaul, Madam, currently working as Health Officer at UNICEF Bihar office. She is a medico-turned-public health professional. Welcome, ma'am. Please start the session with introduction of speakers.
Okay. So, a very warm good morning to all of you, and greetings from Indian Academy of Pediatrics to all our friends, obstetricians. So we work in a team together always, and it is with a deep sense of appreciation for UNICEF and POGSCON to have taken this topic of maternal mortality and every newborn care, giving a special place to this in this session, stressing the importance of promotive and preventive maternal and child health. So for this, UNICEF with his stakeholders, the Pediatric Association, the Gynae and Obs Society, so they have taken huge strides in talking of maternal mortality and newborns. Newborn, being a pediatrician, I will really err on my part if I do not discuss with you what every newborn care means. So, inclusion of every single child, be it a sick preterm or a term healthy baby, all across the globe, is really going to help a lot in promotion and preventive facilities. So we all know that whatever well begun ends well. So with that in mind, we want to stress the point here that the future of the entire world lies in the womb of the mother. So once a child is conceived, we start from there. Neonatologists, we start from there, and we attempt to prevent stillbirths. We again, could I request the others at the back to please maintain silence? So what we do is that we step in during the antenatal period by giving steroid injections. Again, there is good neonatal resuscitation, which of course we'll discuss in length with Prerna. I was just sharing with her that we do need to have plenty more sessions. So good neonatal resuscitation. Then again, next, exclusive breastfeeding for 6 months, which we begin ASAP. Then we step on to the early postnatal care. That is the first 2 days to prevent neonatal sepsis and then improve the lot of these children. So UNICEF with his partner, they have worked relentlessly in taking this message forward by giving us goals for 2025, which I'm sure our distinct speakers, they would be sharing with us. There we have to talk of every newborn care, we have to talk of small and sick neonates, and we have to talk of participatory programs, which is in the form of home visits for these mother and these children. So my friends, with so much so for the introduction bit, and with a galaxy of distinguished speakers that we have today, Dr. Siddharth Reddy. Yeah, so Dr. Siddharth. Okay, so I would request Prerna to introduce our distinguished speaker, Dr. Sarita ma'am.
Good morning, everyone. I think it's in itself a privilege to introduce Dr. Sarita, who is the SPO for Maternal Health for State Health Society, Bihar. She has an experience of over 20 years. She has worked with various capacities in the Health Department of Bihar. Being a medico by profession, she has completed Improvement Advisor and from the Institute of Healthcare Improvement, Boston, and she's also a postgraduate diploma in Healthcare Quality Management from TIS. With her clinical expertise among the public health acumen, her role has been instrumental in strengthening and ensuring maternal health services across Bihar. A lovely human being, a great fighter, for all those who know her personal story. It's a privilege to invite you, ma'am, on the stage.
Yes, thank you. Thank you, chairpersons, Dr. Rashmi and Dr. Prerna. As you said, and as everyone knows that how to prevent preventable deaths. All deaths cannot be prevented, but definitely we should try, and how to reduce maternal mortality. The womb of a mother, actually, as correctly said, that the world actually is going to be born from there only. So what is the health of the baby? That also depends on the mother's health. So how to prevent those births actually, and those mother deaths actually, both the deaths, mother and neonates, how to prevent them? If we identify high risk pregnancies, this is one of the section. If we concentrate on that, then we can actually prevent all those deaths which are in near danger actually. So this identification of high risk pregnancy, this is a step towards reducing maternal mortality, and this is the topic where I am going to speak. And as you know that I work in government, so definitely we are working on this line. So the masses are going to be affected by these efforts. So this maternal mortality scenario, global in India, as you know, must be knowing, I think, these MMR, SRS data, NFHS data, all these. So the global statistics, क्या चला गया यार, कैसे चल रहा है, ठीक है, okay. So globally, you know, the approximately 830 women died daily from preventable causes, which were preventable, related to pregnancy and childbirth. They are not dying because of any disease, but they are dying because of pregnancy and the childbirth process. This number has remained stubbornly high for decades. It's not a simple thing. So, but in India, thank you. This has declined, but still it is very high. In India, MMR is 97 per lakh live birth. The challenges are many factors contribute to maternal mortality, like poverty. India is a poor country. Lack of access to quality health care. This is a very, very important topic. We are discussing was last 2-3 days a year in POGSCON. And inadequate infrastructure, gender inequality, and these challenges require a multifaceted approach. So globally also, wherever the maternal mortality is high, these are the global problems, as well as India is also facing all these problems. So this MMR varies significantly across region. Rural areas, definitely it is high, and compared to the high income group urban areas, and they are having more facilities. So these are the disappropriate burdens. You can find me in India it is 97, Bihar it is 118 right now. So we are in 3 figure. We should come down to at least 2 figure, which we were expecting into 2024. I don't know what will be the data because the period was a COVID period. Sorry. So in India context and Bihar context, you can find it with this map very easily. Where Bihar lies? Bihar lies at 118. We should come down to 70 by 2030. This is the SDG goal. A sustainable development goal is 70. But what we want, why should we wait for 2030? Why can't we come down very fast? And wherever you want to go, when you start doing something like, then initially data comes down very fast, but later on it becomes stagnant because you have to work hard. For each and every death of a mother, you have to work hard. Why did she die? How can we prevent that death? And what were the conditions if she was remain in that area, in the village or wherever she is living, another mother or from that locality only, if she can be prevented from such death. So these should be the strategy after each maternal death. So in India context, only few states have achieved, but India also, you can see the Kerala has only 19 maternal mortality ratio, only 19 per lakh. This is something even a developed country cannot achieve, or they have achieved. Even I found in US it was also in two digit only. So Kerala has done a remarkable work. Maharashtra again, they have focused on this program only and they could reach to this. 33, Telangana 43, Andhra 45, Tamil Nadu 54. So all southern states are doing well. Even this Karnataka has also just reached 70, I think. Just reached 70. Even Jharkhand is doing well. Jharkhand is less population, has separated from Bihar and they are doing well.
Just a pause, ma'am. We
Yes.
would request Dr. Reddy to please be on dice with us as he's the next speaker. Sorry, ma'am, for the...
This audience doesn't need, actually, you all do not need the further description of what are the high risk and why should they be called high risk. But still I am going to enumerate that how we are going towards it. You may add, you may subtract, that your knowledge may help me also here. But what we are doing, risk factor are maternal age, medical conditions and previous medical history. So maternal age below 18 and above 35 all are having some increased risk of complications. Pre-existing conditions are also diabetes, hypertension, heart disease, anything, kidney diseases and other things. Previous pregnancy history like previous preterm history, previous premature rupture of membrane, birth defects also, that these can also increase the risk. So what is the importance of this early identification and intervention? This kind of identification prevents complication and improves outcome. There is a 9-month period time. Even if she is diagnosed in 3rd month, that is in urban area you may be diagnosing early, but when you work for the masses, there are people, women living in villages, they may be diagnosed in first trimester late or in 2nd trimester sometime. So first trimester, we try to diagnose them in first trimester, at least in 12 weeks period time, so that we can diagnose and we can have all the tests in 12 weeks for them. So this is the period where we can diagnose, so the early complication can be diagnosed here only, and then mitigating these risks and prevent complication. And this is going to affect the good outcome or better outcome which could have not been possible if we had not done the 3 ही मिनट तो मैं तो बहुत धीरे धीरे चल भी रहे ना पता नहीं PDF है ये हाँ थोड़ा चलाना पड़ेगा इसे so I should go fast so comprehensive prenatal care so prenatal care is screening risk assessment and monitoring and management you go ahead then empowering women how to actually manage the woman who is pregnant we should empower them by so that the education is the main and awareness is the main two things must be given to them through our health system that they should understand their risk and we assess the service side that where this risky or high risk patient should go and promote during 9 months their healthy habits. Next. आगे. So then the service side, the doctor should be trained, anesthesia should be available, blood should be available, but the gynecologist numbers are very less in our service side. So we try to train them for EMOC, LSAS, that is a 6 months training and we try to fill the gap of this, the anesthetist and gynecologist. Then building capacity of healthcare provider. So as the nurses are the main pillar of the system, so their treatment, that is a skilled birth attendant, Dakshita, gestational diabetes and HIV, syphilis, all tests are being done at the village level also. So we try to diagnose them as early as possible. One program where we are focusing on high risk pregnancy only, this is called as PMSMA, and here I can say the the POX people are supporting us like anything, and you people are doing a fantastic job. We are working with you people also. So these are the categories which we have actually selected: severe anemia, pregnancy-induced hypertension, gestational diabetes, reactive for HIV, syphilis, hypothyroidism, tuberculosis, malaria, previous cesarean section, hepatitis B pregnancy infection, teenage pregnancy, high fever, history of stillbirth, RTI, STI history of congenital malformation, RH negative, early primary, grand multipara, short stature, bad obstetric history, twins or multiple pregnancy, cephalopelvic disproportion, abnormal fetal presentation, any other condition which can be diagnosed by the. So these are the 25 conditions where we are working focused, and we try to find all conditions from the field and we try to refer them as early as possible. We try plan their delivery at least at a better hospital in the beginning only. 2 minutes. So this is the engagement of volunteers. So in this is a picture you can see. Many of you are here. So in 2024-25, 106 urban facilities have been supported by you people. So these are the IEC material we have developed. So this is the vision of our Surakshit Matritva Ashwasan. This is known as Suman also in short, to initiate, this is the initiative for zero preventable maternal and newborn deaths. Vision is to create responsible health care system which strives to achieve this zero maternal and infant deaths to quality care provided with dignity and care, and to end all preventable and maternal and newborn deaths. So all beneficiaries are pregnant women and mothers up to 6 months, and all sick infants are also taken care by this program. So what are our broad pillars are service guarantee, health system strengthening, monitoring and reporting, community awareness, incentive and awards, and IEC and BCC. So this improving maternal health outcome strategy and recommendations are by fostering collaboration, investing in infrastructure, empowering women, we can collectively work towards reducing maternal mortality and ensuring safe and healthy pregnancies for all. We must focus on prevention, early identification, comprehensive care. So please, united we can do this endeavor, and we are going to prevent all preventable deaths. I hope so. And if in my during my work, if we can reduce even MMR by some point, that is an achievement. And for the last I think, say, NHM started in 2005, and right now we have from some 500 something to 118. We never got up. Every time we are going down and down and down. This time, at least it should come down to 2 figure, below 100. Thank you.
Thank you so much to Sarita ma'am for a beautiful presentation. Now for the next one, we have Dr. S. Siddharth Shankar Reddy from UNICEF. A very dynamic personality. All of us are well aware of his presence on stage, off stage. He is currently working as health specialist with UNICEF, possessing over 18 years of rich experience in public health and public development. He is graduated from the University of Melbourne on health systems, graduated from Emory University, Atlanta, United States, and he has demonstrated successful emerging response, developed roadmaps, and showcased innovative ways to take care. Not to keep a time between you and Dr. Siddharth, I welcome you, sir.
Thank you very much, chairpersons, and also I would like to thank the POGSCON secretary, president, and also all the office bearers and all the delegates for giving UNICEF the opportunity to present on ending preventable maternal mortality. Thank you very much. So first of all, I would like to thank Dr. Sarita, because she is so emotionally attached with the maternal health program since the last many years. So whenever I will ask her on to present on maternal health, she will speak, and she will be speak by her heart. And also I would like to thank Dr. Sampath Kumari, because she presented the HELP syndrome, the clinical health syndrome. Now I will be present the public health syndrome, and I request all of you. I will request all the POGS members and POGSI members to help Government of Bihar and help UNICEF for achieving this HELP syndrome in public health. So thank you very much. With this, actually, I will be just presenting this ending preventable maternal mortality. As Sarita madam already mentioned, that actually the SDG target is 70, but we are still a lot have to achieve the SDG targets. So we have to do a very robust programming in Bihar specifically, because UP and Bihar is contributing around 30% of the overall maternal and neonatal mortality in India, and also around 10% of global contribution. So we need to work very hard on this. Regarding this MMR statistics, already Sarita madam has spoke about this, so I will not go about the detail. But if you see the map, where actually the southern and western states already achieved the SDG target of less than 70, and almost the north and the northeast states, they also on the verge to achieve the target of 70. But the central part of India, mostly where the EAG states are residing, you see that we are actually far away from the SDG target. So we need to work very hard, especially states like UP, Bihar. Those are contributing not only in terms of MMR ratio, but also in terms of huge mortality in absolute number. So India is actually second in globally in terms of maternal mortality. Similarly, Bihar is also second in India in terms of maternal mortality, and we need to work very hard. And we are yet to achieve 48 points, and it is actually requiring around every year we need to reduce at least 7 points to achieve the 70 targets by 2030. So already Dr. Sarita has mentioned that the high burden states, that 11 burden states, that is 8 EAG states, then Haryana, Punjab, and West Bengal. These are actually the states actually where actually they are contributing around more than 80% of the totally maternal mortality burden. And the challenges are like low antenatal care, not only care, but in terms of coverage, but also in terms of quality. There are a lot of teenage pregnancies, especially if you go to West Bengal and Bihar. Home delivery, high home delivery packets are also there. The CMOC services, FRUs are not functional. In Bihar, actually, we need 217 FRUs, but only 86 FRUs are functional till date. High risk pregnancy detection is also very less. In Bihar, actually, we are actually in around 4%, though we need to achieve around 10 to 15% of high risk pregnancies, but actually we are only recording and reporting and following around 4% of the high risk mothers. USG system is also not there in the PMSMS side, especially in the block level, though they are catering around 3 lakh population, but hardly we have USG services. Then postnatal care is also not very good situation. Tribal areas like Chhattisgarh and other states are there, but in Bihar is also some part is burdening to Jharkhand is also having some tribal affected areas. There is a lot of shortage of infrastructure, human resources, and a lot of challenges in operationalizing and implementing various maternal health programs. So we need to work very hard on this. This is actually the list of 11 states and the high risk blocks, actually high risk districts that actually contributing majority of the maternal mortality and also neonatal mortality. If I will go to Bihar, out of the 38 districts, 9 districts are very actually poor performing district, and I would like to urge here the POGS and POGSI members, please focus on these districts to achieve the target of 70. These districts are Araria, Kishanganj, Katiyar, Khagaria, Madhepura, East Champaran, Sitamarhi, Sior, and Saharsa. Please, I would request, please also you volunteer your team members from the state Patna and also from the district and the nearby district to support these districts. If you see the maternal mortality, every hour one mother is dying in Bihar, and around 10 mothers die per day in Bihar, and the total absolute number is around 3,800. It's very high. It is second to UP. So now I will come to the EPMM strategy. What is the actually the targets and goals that is set for India and also for globally by 2030. So target 1 is actually at least 90% coverage of 4 and more antenatal cares. Not only coverage, that should be also with quality. Second target is 90% births attended by skilled birth attendants. That should be also happen. And unfortunately in Bihar, we are having high skilled birth attendants, but this number is not coming because we also deliver around 30 to 40% mothers at the private health facilities, but that number is not coming to us. Similarly, third target is 80% early routine postnatal care within 2 days. That is also not happening. This is the state level target, but at a subnational level, if you go, then 80% districts should have a coverage of at least 7% ANC4, 80% skilled birth attendants, and 60% postnatal care. So next target for ending preventable mortality, that is actually more than half of population within 2 hours of emergency obstetric care. Means someone, if you develop any complication in the home, he or she should be reached and the facility, and also the care should be started within 2 hours. That is a challenge in Bihar in context of big districts where actually we have one FRU at the district level, and if someone developed any complication in the village level, who is around 80 km, 90 km, 100 km, it is very difficult to start the complication management within 2 hours. Similarly, target 5 is 65% women making own informed empowered decisions. Now it is not only providing services, but also we have to empower them through giving the positive messages through the public providers, through the people those are working at the community like ASA, ANM, ASA facilitators. Those should be also reach the community and provide the messages to the mother and the adolescents specifically on the empowerment and how to avail the services where the services are available. And the last one is actually also ending newborn action plan. I will specifically speak for the our chairperson. Here the target is to at least we have at least level 2 plus CPAP services at all the SNCUs. Level 2 means actually in the SNCU we will be providing MNCU services where mother newborn kept together, with immediate kangaroo mother care services, and also family participatory care services are also provisioned, and developmental supportive care. Developmental supportive care means you know that actually newborn fetus stays in around 40 weeks in the womb. When if he comes before the 40 weeks, that is in preterm condition, then it is very difficult for the newborn, the fetus to survive outside, because you know the condition inside the womb, the temperature, the sound, the light, the pain, the position, that is very different, and when it comes to the outside, it will be very difficult to adjust that newborn outside of the maternal means womb. So actually that develops, that newborn will develop a number of sequelae like developmental delay, abnormalities, and mental retardation. So that's why we also planning to start developmental supportive care along with antibiotic stewardship program. So I will request that actually all of you, because it's not only the concern of the new pediatricians, the maternal experts like gynecologist also is very much should be very much supportive for ensuring the developmental supportive care, and also the level 2 care in the SNCs and labor rooms. So these are actually the districts where actually we have having ANC, but unfortunately the HIV testing coverage is very low. In Bihar you say only 6.1% HIV testing is happening, HIV and syphilis testing is happening. Similarly, if you will go to the next, the expenditure, the government expenditure, you see the left side, the red states are actually, those are actually contributing highest maternal mortality in India, and also having very less expenditure in terms of government public health facilities, and also the overall expenditure both public and private health facilities. But in the right side, those states are actually performing very well in terms of maternal mortality, have a very good expenditure in the public sector and also in the private sector. So where actually these mothers die, and how actually we should, who are actually the persons they are in the ground level, they are supporting. So we know that there are 3 delays. There is a delay in community at the home, delays in the transit, and delay in the hospital. If there is a delay in community, actually here the ASA facilitators, key healthcare functionaries, they are the responsible. They should immediately inform the situation. Similarly, in the transit, if that is happening in the ambulance, then the ambulance technician, district nodal officer, or medical block medical officer, they should actually inform. Similarly, in the facility also, if there is any delay, then the medical officer should immediately take action to prevent all these challenges. We also know that what is the actually major causes of mortality. We know that hemorrhage, anemia, sepsis are the major causes, but unfortunately when we are doing actually our maternal death review, unfortunately around 52% of the maternal mortality causes we are unable to ascertain. So these are the challenges we are facing. So we need your support, fully support in this, to improve the maternal health scenario in the state. So I will not go to the strategies. Already a lot of things are happening. I will just request you, please focus on the existing national health programs, existing state health flagship programs, and also the delay areas, in the tier 3 delay areas, to improve the overall maternal mortality situation of the state. These are the actually standard strategies and guidelines and principles for achieving ending preventable maternal mortality by 2030. So the 4 guiding principles for empowering women and girls, protect and support both mother and baby, both SNCU and labor room, ensures state ownership, leadership, and apply human rights framework. Cross-cutting is ensure budget allocations and also improve the services. And these are the 5 objectives that actually needed to be improved. My last slide is very important here. Actually, I will urge here to the POGSI and POGS members that please provide voluntary services at the government health facilities. Yesterday, during the inaugural session, our new president, POGS president, in her commitment number 18, she urged all the POGS members to provide voluntary services. So I will request again, I am reiterating the same one, to provide your voluntary services, especially at the district and FRU level, to improve our C-section. And also in the EPMSMA side, please volunteer yourself at the district level and the block level. Popularize all the government programs and schemes are available with your clients, the mothers. Then also I would request POGSCON to also make special efforts to mobilize volunteers in high priority districts. Like high priority district, I mentioned 9 high priority districts are where the maternal mortality is very high. Please mobilize your volunteers to that district. And the last but not the least, please also report all your indicators, whether it is the delivery, cesarean section, immunization, birth, stillbirth or live birth or neonatal death to the public health system, through the HMS system, so that you can plan effectively to prevent all these things. Thank you very much once again for giving this opportunity. Thank you very much.
So thank you so much to you, Dr. Reddy, and I must take this opportunity to just put in a word about developmentally supportive care that sir has talked. It is extremely, extremely important for us to recognize which children are there who require care. For that, there are a various number of scales available, the Bailey scale and all, and then we have Dasi, which is the Indian version. So we neonatologists and our entire community is at your service. We can form a partnership and do this developmentally supportive care for children. Another word, like sir had mentioned, for CPAP. So of course, many trainings have been sponsored for CPAP by UNICEF. I have myself been a part of them in training people. I would request our obstetrician friends to have a delivery room CPAP to improve the lot of preterm children. So with that, thank you so much.
Thank you so much.
I'll just take a minute to leave every one of you with 2 emotions, and thank you so much to our esteemed panelists for technically going into the detail and giving you a vision of where Bihar is and where rest of the world stands. If you could all just close your eyes for a minute and remember the time when you wanted to become a doctor, and not just a doctor but a gynecologist. Remember that feeling. Why did you want to become a gynecologist? And on the other side of the one side of the brain you can keep that feeling, another side of the brain you can keep a feeling of, do you have any idea of how many mothers died in this 3 days of POGS conference in Bihar? About 30 women would have died in this three days of where we were celebrating this conference. Now remember both of these feelings. If there's any synergy between the two, I'm just leaving you with those feelings to kind of nudge you back to the days where you dreamt of being a gynecologist, and it is still a dream for many who could not, but you have been there. So it's up to all of us to kind of change the scenario which was presented in the slides. Thank you so much.
Thank you so much. Can I request the chairperson and the speakers to please join us for a photograph next to the backdrop? Thank you. Can I request the chairpersons to please join us for the next session? We have Dr. Sushma Pandey, Dr. Lata S. Divedi, Dr. Bharat Prasad, and Dr. Nibha Mohan. Can I also request our first speaker, Dr. Shista Basu ma'am, to please join us on the stage. Her CV is onto the screen, so again she doesn't need any other introduction. Dr. Nibha is also making her way onto the stage. Can I request Dr. Vaishali Chavan from Pune to also, she's from my city, so many. Can I request Dr. Usha to please join us as the chairperson? Dr. Shista ने मेरे को बोला है कि वो टाइम पे चलाने के लिए मुझे मदद करेंगी. So can I request Dr. Basu to please start with her talk? Yes, ma'am.
And good morning, everyone. At least let us introduce her topic, Shista and Basu madam. She's our guest speaker and going to give a keynote address on patient-centered communication and shared decision-making. So over to you, madam, for your beautiful presentation, as you are.
Thank you so much for your compliment. And yes, I always feel that these tables should be much lower. Because you cannot see the audience. The Royal College, in fact, where they have such tall people, they stand like this and they talk. So you can imagine how low their table is, and we make it so high. So I think that is something we should do. Anyway, without taking much of your time, this is a topic which most would find very uninteresting and not relevant, but believe me, it is so very relevant in the days to come and even in the current situation. We keep talking about violence against doctors, etc. We can't change all the patients, that will take time, but let's start with ourselves and see what we can do to mitigate that risk also. Apart from that, so we have a Society for Communication in Healthcare, and people are welcome to join. So why do we need to have this kind of a topic? Shared decision, person-centered medicine and shared decision making. It's because the changing healthcare scenario. You have more educated patients. You have Google and Yahoo and so many other websites, personal websites, websites run by people who are not even qualified. So you've got that mixed, atmosphere on the web, and people quite often come with all those things in their mind to when they come to a doctor, sometimes having made a decision themselves. So first of all, we must understand that the World Health Organization has taken this very seriously, and in fact, they are talking about communication in healthcare in a big way. The National Board has started a committee, and we have designed a curriculum which will be incorporated into the examination system of the National Board. The ATCOM module is already there with the National Medical Commission, but we don't have faculty to train the students. That is a big problem. And therefore, we need to train people to be able to teach communication and all the factors some of the factors that I'm going to mention to the students. You see, everybody is a good communicator, otherwise you wouldn't be sitting here with a good practice. But apart from that, how to transfer that knowledge to the next generation, the Gen Z, which has grown up on mobiles, etc., requires a structured training. And that is what we are aiming at. So WHO says there is person-centered care, where you don't see the patient as just as gynecologists, as just the uterus, tubes and ovaries and the vagina, or the breasts if we go a little further up. It means the whole person as a whole has to be treated. And people-centered care, excuse me, sorry, there's a lot of talk going on.
Excuse me, please, everybody is requested to come in front and take their seats so that we can enjoy this such an important keynote address going on.
So when we talk about people-centered care, which is not only the individual, the person, the family, which you are already doing in your consultation. कि घर में कौन है, किससे हुई, कहाँ रहती हैं, क्या खाती हैं, we are already doing that. But we have to teach this to our future young budding doctors, and we have to learn that structure. So if you look at an individual, that individual has its own knowledge and attitudes, then their family friends which influence their attitudes, then the organizations which influence their attitudes, for example, the schools, their workplaces, the peer pressure. डॉक्टर ने तो कुछ कहा, घर workplace में किसी ने ऐसा कहा कि अच्छा आपके डॉक्टर ने ये नहीं बोला, उसने ये नहीं बोला. So all this confusion occurs. Then the community at large. Even the maid can come up and give their own advice to you. Some of them may be justified, and you may think, okay, itna bura bhi nahi bola, but we have to understand how to manage all that which is going on in the patient's mind who is sitting in front of you. And then, of course, the public policy that the government has, and the government is also requesting us that we should go about it in a big way. So person-centered care, we have already heard the discussion with, respectful maternity care, etc., which is a direction, in the right direction. We need to incorporate that, but it means compassion, coordinated care. Coordinated care is not fragmented care, means कि एक फिजिशियन देख रहा उन्होंने कुछ लिख दिया, एक सर्जन ने देखा उन्होंने कुछ लिख दिया, और गायनेकोलॉजिस्ट के पास आए तो उन्होंने कुछ लिख दिया. This is not coordinated care, it's fragmented. We need to bring about coordination and personalized to that individual. We talk about individualized medication, but we should go further than that, and it should be individualized management of the patient. So Institute of Medicine has decided respectful and responsive care. I will not go into the details, which I have already said. So what are the elements of the person-centered care? First of all, recognize the patient not as an organ, identify as a person. Come to know the person with a little short dialogue. For example, short dialogue, how do you find out all the details? You don't have all the time in the world to sit down and find in details. So we teach you a structure in communication, how to get to the bottom of the problem in that limited time that you have, so that the patient doesn't keep on wondering. How do you bring them back? What is your style of questioning? How you should modify that questioning so that you get maximum information in the shortest possible time. Then maximizing choice and autonomy. Don't make all the decisions. We'll come to that when we could talk about shared decision making. Build up a relationship that makes it much more easier, and a supportive physical and organizational. For example, who is the security at an organization, who is the ward aya, who is everybody, they should all be part of this training. It is not only limited to the doctors, but we need doctors to become trainers, and that is what we are requesting you seriously. So principles of patient-centered care, personalized, coordinated, and it enables the patient to make a decision so that we can make a justifiable decision and the patient doesn't feel that something has been thrust upon them. So what are the building blocks of person-centered care? First, dialogue based on open-ended reflective questions. Now, I want you to concentrate on this. Open-ended reflective questions. Most people would probably have a good idea of what it is, but many people would not know and how to ask a reflective question, how to ask an open-ended question, how to ask a close-ended question, and these styles are to be used with different types of patients so that you get the maximum information out of them. So this is also a part of learning. Then understanding the preferences, of course, involvement of family, and then we come to listening and empathy. You must always be in a position to show empathy. The older generation showed empathy naturally. The younger generation, I think they are so much, they have grown up on an atmosphere where I think empathy has become taken a back seat. And believe me, in UK, they have actually started centers for training, because it is not something is inborn. Some people may be naturally inborn, depends upon your social structure and your family structure, where you learn empathy. Arey aisa nahi, usko dekho, ye bura lagega, ye karega, all these kinds of things. But now they have realized that it can be taught to an individual, but it has to be taught in a structured way. So challenges, why is the challenge? Because there is a complexity of treatment options. ये भी कर सकते हैं, वो भी कर सकते हैं, वो भी कर सकते हैं. And the nature of the care is fragmented. जी हमको तो उन्होंने ऐसा बोला था, उन्होंने ऐसा बोला था. And here we have to first look at yourself, protect yourself, be up to date, and don't hesitate ever to say, I don't know, I will look it up and get back to you. Never hesitate to say, admit that there is something that you are talking. It's not a question of, I know everything. Then we come to the next part, the shared decision making. We have understood what the person is and how that person is to be treated, and the shared decision making is the core feature of good healthcare. And why do you need to know about it? Because the National Committee for Quality Assurance, the Accreditation Association for Ambulatory Health, Joint Commission, etc., all organizations have this, they check this whether you have it in your system or not, before they give you the certification. And they have to include the standards to shared decision making, and only then will you get the certification. So that also makes it more important to understand the concepts very clearly. They have analyzed after the shared decision making, it lowers costs, lowers litigation, and reduces patients' selection of major elective invasive surgery in favor of more conservative treatment options. We should not be in a rush that this is a patient, iske upar hum kya kar sakte hain. That attitude, which sadly to say, we have seen in some of our colleagues, but that should not be done. It should be the patient making the final decision rather than you pushing, nahi, aap ye karwa lijiye. You can tell them, if you don't get this done, these are the pros and cons, or if you don't have the time, you can go and read up, discuss with your family, come back again, we'll have another meeting about it. But unless it's a life-threatening emergency, never push your things. Let them, give them time to mull over it and come back to us. Especially in obstetrics and gynecology decisions, because it is often sensitive, life-altering choices, and a lot of emotion and cultural dimensions. For all other specialties, person is sick, you can only make them better. In obs and gynae, it is supposed to be a happy event, and everything that goes wrong is the doctor's fault. So here you are, have to be much more sensitive. What are the criteria for decision making? Description of the nature of the decision. Now, how do you help them to come to that decision is also part of the training when we talk about it in Society for Communication in Healthcare. How to bring back everything so that the person arrives at a decision rather than remaining floundering all the time. Discussion of alternatives, discussion of risks and benefits, discussion of related uncertainties. Why we don't know. नहीं करोगे तो उसका क्या होगा हम नहीं जानते. For example, if we say cystic hyperplasia has such and such percentage of 10 to 15% of turning into malignancy, who knows, but that patient may never have malignancy because there's a larger number which is not going to have malignancy, but there is a small number who's also going to have malignancy. So you have to admit that there are certain limitations. Assessment of the patient's understanding. Talking to a person from the village, talking to an educated person, talking to a mobile-driven and an IT professional, they can all be a different ball game altogether. And we tell you how to handle each one of them in a different way, what the questions should be, they should be modified. And then we have to elicit from all this, what is the patient's preference. There are 4 patterns of decision-making, which was classified as early as 87. One is physician-controlled, which was done in most of the times in the previous times. Then is patient controlled, then it's jointly controlled, and then it's the family controlled decision making. So these are the different kinds of decision making. And so one is the choice talk. What are the risks of a person having suffering from something? What are the different cares? How we use the decision aids to help them arrive at a decision, and the opinion of the surgeon and the oncologist. This is an example. Then we give them the options that they need to make a decision. If you want more details, you can come back with details. There are patient goals and values which we have to keep in mind, that if there is anything that you want to ask again, go home, think about it. If there is no time, then we have to also how to communicate and come to a shared decision making in an emergency situation. That is a separate type of training that is required, because emergency situations are different from elective situations. And then match the treatment to the patient goals, because the patient will only be happy if it matches with their thought process. Otherwise they'll think, यार मेरे को तो पता भी नहीं था, उन्होंने बोला करो करो करो, नहीं तो कैंसर हो जाएगा, और मैंने करवा लिया, और बाद में फिर लगते हैं सारे रिश्तेदार अपना ज्ञान देने, and they begin to think कि मैंने कहा कि जो सोचना है ना, जितना ज्ञान लेना है सर्जरी के पहले करा लेना चाहिए, उसके बाद जब एक बार हो गया तो हो गया फिर nothing can be done. And then we come to the decision talk. We clarify everything, and we know this is also a structure. How to clarify, what are the questioning and the statements that you make, how do you clarify the patient's values, caregivers and partners, unke bhi values le liye, and then we come to a decision. So this is shown in just a slide, but this entails maybe even a big whole workshop when we go into teaching people how they do it. So the SHARE approach is seeking participation, helping you explore, compare treatment options, assessing your values, reaching a decision and evaluating your decision. That's also important. Okay, you have decided to do this, and the pros and cons are going to be this. What are the barriers to implementing shared decision making? Lack of knowledge. Lack of knowledge works both ways. We may not have enough knowledge of the type of case we have. We don't know everything about oncology as generalists, as general gynecologists. So admit that, lack of knowledge on our part, and of course can you imagine the lack of knowledge on the other, who may be armed with all the Google knowledge, and sometimes they may put you in a fix. Oh, is that what's अभी latest ये निकला है, मैंने Google में पढ़ा है, मे बी आप ही को नहीं पता है कि क्योंकि आप या तो काम ही कर लें या रोज Google ही पढ़ लें अगर आपको सारा information चाहिए. So then you can always say, okay, we will look into it and come back to you on that. Or you can go and meet the onco person. It's simple. The more people you have multidisciplinary, it will give you better idea. Then there is clinical inertia. That is on part of the gynecologist. We have to tailor our communication as with the patient, uska bhi level of understanding. And believe me, don't think that the people who are illiterate from the village, they don't understand. I found them, sometimes they are much more wiser than the people who have grown up only on the mobile. So it is important to understand that also when we give them any decision. Now clinicians के साथ एक थोड़ा inertia होता है कि ओफो बाकी ही इतना पढ़ना है, इतना करना है, उसमें एक और चीज़ ये भी जोड़ दी गई है, तो कैसे काम चलेगा? So they agree कि हाँ होता है, हम लोग करते भी हैं to our limit capacity, but I think we need to improve that. We have to, the Gen Z, now that is a different workshop or a training altogether. How do you communicate with different generations, including the generations who have come up, whether it is medical or even otherwise? So that is to be taken into. So we feel thoda lethargic, yaar bahut pad liya, ab isme bhi kya jodna hai. That is something your call, but for the benefit of the patient and for the society, I think we need to give it back to them. And sorry, I won't take long, I won't show the videos. Health system obstacles होते हैं, crowded OPDs, barriers to integrating into the routine care, ये थोड़ा सा शुरू में मुश्किल होता है. Benefits तो खैर बहुत है, increased patient satisfaction, better adherence, greater treatment, better quality decision making. Challenges, as I have already mentioned, the treatment things are so complex, और हिंदुस्तान में तो और भी complex है, with so many other pathies also thrown in. Not only different specialities, it's also the different pathies also which are coming in. So it becomes much more complex for us, and the fragmented nature which I have already mentioned. So what are the strategies? Education, training, health system strategy, increase engagement of the doctors, the patients and everybody. And there were certain examples I was going to give you, but I think I've run short of time, perhaps another time. I'll just take one of them, choosing a mode of delivery. A pregnant woman with history of previous LSCS is deciding whether to attempt a VBAC or undergo a repeat CS. So explore what the patient wants, start there. Get her, the sooner you get her ideas in, it will be easier to tailor your conversation accordingly. So they might think of avoiding surgery, then you can tell them the individual history, okay, you have decided, but these are the pros and cons, etc., etc. So by combining shared decision making, you can come to some sort of a decision. These are prenatal screening for genetic conditions. This is another very common thing. You get a result which is normal, which is too late. I think when you counsel them to have the tests done, that is the time when you should tell them what is the outcome going to be and what are they going to do if the result is abnormal. Many people, I have known people in my own life who have said कि नहीं अब जो result होगा मेरे को इतने मुश्किल से I will carry on. और हम test पर test किए जा रहे हैं, उनका भी stress बढ़ा रहे हैं, अपना भी, but you need to the documentation. So how to document all these things in the proper way is also a part of the training. So I will just stop here, and there are many issues that I would have liked to continue. So how do clinicians need to adopt? The clinicians, they have to develop their consultation skills, and they don't think that the patients won't make the right choices, they won't take their medication. Just because you tell them to take something, they will take it. No. So good communication is the bottom line, and please get out of this mindset that good communication है आइए जी हम आपसे बात करते हैं बताइए क्या करना है. It is out of this purview. It is not that. It is far more. It is the intricacy of going into the depth and getting the maximum benefit in a structured way. And the counseling, so effective communication is vital. Hospital setting is difficult, but we have to devise a system. So what needs to be done? Classic parental doctor-patient relationship, a participatory approach. Don't decide on the plan of management, etc. And you need to have patient coaching programs, centers for shared decision making and communication. And that is why, please, I invite you to join the society, because that will enable us to create more faculty also. We need more faculty. We don't have enough faculty in this. The government is also, the national board has been very proactive, and they have actually introduced this, and probably from the next time it will be in the FAT examination, and then ultimately it will also be in the final examinations. Part of the, I think this is. NMC has introduced, and they have started training, but it is not in the structured way that, it's an abstract, okay, I'll talk about that later. So communicate, yes. There is one thing I would like to add here, and this is a food for thought. When results in healthcare are taken, doctors, when they themselves are patients, they generally choose less treatment for themselves than for the patient. Keep that in mind when you are also counseling a patient. So if you don't take a particular treatment, then you should also think कि ये भी दे कि नहीं दे. And the India's Charter of Rights has these 17 clauses which says right to choose alternative treatment, right to a second opinion, right to patient education, there are a lot of them, and right to be heard and seek redressal. These were many videos, but I think we'll just skip them.
I mean, we'll have to go to the conclusion.
Thank you,
Yeah.
madam.
Welcome to join this.
Excellent talk, madam. And the way you spoke about coordinated, compassionate talk and communication and the empathy. These are, I think, the skills that we all should be practicing, and the younger generation should be taught about it. So thank you very much, ma'am.
Thank you, Shishta, for a wonderful presentation. I will just ask you that if a doctor put herself in the place of patient, then what would we like to ask, or what questions all come into our mind? If we think in that way, then we would like to have answers for all our questions, all our queries. So in this communication, I think we can go that way, then we will know the importance of this communication. And for this, we would like to open a chapter in Patna also, and for that Amita has got the registration form, and that is free for now.
For 1 year.
For 1 year. And a lot of people I would like to join this venture. And
with that, I would like to communicate it's getting late, so we'll have the next speaker. Yes, please.
Thank you very much.
Thank you.
Thank you. Good morning. Second speaker is Dr. Shukanta Mishra. Please, you are welcome on the podium. And his topic is assessment and monitoring of monochorionic twin pregnancy. So, Dr. Shukanta.
Good morning.
Topic.
At the outset, I believe you all will excuse me for my voice.
Dr. Shukanta is the professor and head of VIMS, Calcutta. And okay, Dr. Shukanta, please go ahead.
Respected chairpersons and the kind delegates, excuse me. When there is a call from Patna, I had to come. What can I do? It is something like coming back to home again and again. And thank you, Dr. Meena Samant, Dr. Amita Sen, and the entire organizing team for inviting me to be a part of this wonderful conference. Now, I was supposed to talk on monochorionic pregnancy. You know, yes, Sita is there. I'm just managing, I'm not managing, I'm just trying to assess it. But Sita is there to take care of the management. You see, dichorionic twin is possible when there is dizygotic twin. Dizygotic twin can only produce dichorionic twin. But when there is monozygotic twin, there could be both dizygotic and both dichorionic and monochorionic. I think my voice is creating problems. So 30% of all twins are monochorionic. That we need to know. Why this monozygotic twin creates this monochorionic twin and dichorionic twin depends on the time of splitting. Now you see, 30% of these monozygotic twins, they become dichorionic diamniotic, that is dichorionic type, and 70% becomes monochorionic diamniotic type. 1% becomes monochorionic amniotic type, and the rarest variety is the conjoined twin. Now this is because of the time that decides what type of monochorionicity will be there. Now if this split occurs within 3 days, it will be the commonest variety. Within 3 days it will be dichorionic. Beyond 3 days, within 8 days, it will be monochorionic diamniotic. And thereafter, subsequently monochorionic, monoamniotic, because the amnion has already developed and splitting has occurred beyond that, and subsequently conjoined twin. Now we all know multiple pregnancy or twins are responsible for so many complications. Just to name a few: preterm birth, preeclampsia, PPH, and some neonatal problems. So monochorionic twin is very special because they have got tremendous placental vascular anastomosis. They share a common placenta. The peculiarity of this placenta is that there are artery to artery and venous to venous anastomosis, which is there on the surface of the placenta. Besides that, there is artery to vein anastomosis, which is capillary type and is present deep inside the placenta. Now, when these connections are bidirectional, it doesn't create much of problem, but when it is unidirectional, and becomes unbalanced, then it can lead to a number of complications which are very special and unique to monochorionic pregnancy. And these are twin-to-twin transfusion syndrome, selective growth restriction, twin anemia polycythemia sequence, twin reversed arterial perfusion syndrome, and of course, single fetal demise in this particular case is also a unique problem. In fact, monochorionic twins have higher risk of both fetal and perinatal loss compared to dichorionic twins, as you can see from all these complications that they can have. Besides that, yes, despite being monochorionic, there could be discordant chromosomal anomalies as well. So these are some of the problems the monochorionic twin is associated with. So the basic problem lies in sharing of the blood. There is single placenta and there is sharing of the blood, and this becomes common when there is unbalanced sharing of blood. Now, how to assess this? Being a generalist, we need to know that how far is our duty, because the management of monochorionic twins should be done primarily by the fetal medicine specialist, and persons like Sita is, so you need to refer the patient to them. But prior to that, as a generalist, we need to do certain things. We need to assess. If you are fortunate, if you get a patient that you know from your first trimester ultrasonography, maybe within 8 weeks or 9 weeks, that yes, this is a case of twin pregnancy, then you need to establish a few important things. What are those? First thing, that you have to repeat a ultrasonography at this golden window period. Now, what is this golden window period? That is somewhere between 11 weeks to 13.6, that is 14 weeks, with a crown rump length of 45 to 84 millimeter. And this is the time that gives you the maximum benefit of having maximum advantage. Like, you can not only establish the fetal viability, but at the same time you can date the pregnancy. If it is below 14 weeks, you can date the pregnancy by looking at the crown rump length of the larger twin. And if it is beyond 14 weeks, of course, dating can be done by looking at the biparietal diameter of the larger twin. You have to assess the chorionicity, which is most vital, because as I said at the beginning, monochorionic pregnancy are always at much, much higher risk compared to dichorionic twin, although both are at risk. So that needs to be established to exclude some of the major congenital abnormalities, so that you don't embark on some of the interventions that you need to do in future if at all it is required. So you need to exclude those like anencephaly, holoprosencephaly, those can be diagnosed at this point of time. You need to label the fetus, which one, I mean, there are different ways of labeling, I'm coming to that, and screening for aneuploidy if at all it is required, and if the patient party opts for that. But in India, I believe in practice, we always go for screening for aneuploidy. Now, to establish the chorionicity, which is often asked in the exam, and we all know that chorionicity is best determined at this time of ultrasound, this golden window period. And it can be determined by three important things. One is the number of placental masses. Second is the attachment of these intervening membranes to the placenta, how it looks like, and thickness of the intervening membranes. Now, this composite picture should give us an idea what sort of chorionic pregnancy you are dealing with. Is it monochorionic or dichorionic? Now, this is very accurate, but not 100% sensitive. Even 3% of the monochorionic pregnancies can have two separate lobes. So it could be bilobed placenta. One should be careful about that. And one should also try to understand, on many occasions, this subjective interpretation of the shape of the attachment of the placenta and the intertwining membrane can be false. So once you determine the chorionicity that needs to be followed up, subsequent in the second trimester, to looking for the concordance of sex. If that is maintained, fine. If that is not, then of course there is a problem. Now if the patient comes beyond 14 weeks, what should we do? There's only one way of looking at this, that is look for discordant sex. If you find this a boy and a girl, then you know you are dealing with dichorionicity, not otherwise. So if you don't have any other problem, then you consider this pregnancy as it is a monochorionic pregnancy and manage it or assess it accordingly throughout. It's very important once you identify that it's a monochorionic pregnancy that you need to counsel the patients. Dr. Basu was mentioning how to counsel. First thing first, you need to inform the patient that you are having this. What are the consequences of this? And as a result of those consequences, what you are supposed to do? And when should you refer the patient? What is the cost involved? What is the outcome? What are the outcomes? Whether they're interested to take part in this journey or not. So everything needs to be discussed in details. And also you need to consider whether you have got facility for good fetal medicine specialist or not. So all these points should be taken into consideration. Now, yes, after discussion, and then at the same time you need to level the twins. Now, at one point of time, particularly when we were students, we used to consider the baby who delivers first vaginally is the baby 1 or 2 in 1, and the one which comes out second is a 2 in 2. But that's not acceptable nowadays. Because when we can identify all these many abnormalities even much earlier, and we might have to intervene with the help of the fetal medicine specialist, we need to identify accurately which baby is what. Otherwise, this constant management throughout pregnancy and thank you very much, and throughout pregnancy and the intervention that is supposed to be done to the correct twin is very important. And that is why it's important that the relative position of twin to each other, like not 2 in 1 or 2 in 2, but something like lateral medial or vertical or lower, because that gives you the possibility of opening up some new things, like the birth order can be changed, particularly following cesarean section. So that takes account of this fact. Now, yes, that's the time we go for congenital abnormality, I mean chromosomal abnormality assessment. Now, how to do it? Again, there is a suggestion that first thing that they are not at increased risk of fetal chromosomal abnormality compared to dichorionic and singleton pregnancies. But we have to do it, even we do it in singleton pregnancies. So the test that needs to be followed is the combined screening test. What is that? The assessment of the nuchal thickness and the serum analytes, particularly free beta HCG and PAPPA, pregnancy-associated plasma protein A. Now, the problem is that while assessing the nuchal thickness, there is a tendency, because of unequal sharing of the blood, that nuchal thickness would be large. But there are also observations that though there, where you find that nuchal translucency or NT is larger than expected, then these are the babies they are at risk of developing certain complications, particularly TTTS, twin-to-twin transfusion syndrome. And if it is, there is discrepancy in more than 20% in both the twins, then there could be early development of TTTS. So there are some suggestions or indications from this as well. So you need to take care of that as well. Detection rate may not be as good as singleton pregnancy, but pretty high. But one must understand false positive rate is also very high. The most important point at this juncture, we must understand that this is pregnancy specific in general. That means when you are talking about the risk is the entire pregnancy, vis-a-vis fetus specific in dichorionic pregnancy, when we are talking about particular fetus. So that you need to also understand. If the lady comes after 14 weeks and opts for this screening test, then you have to go for, as usual, quadruple test. NIPT test is a new avenue. One can try that, and it appears that the results would be like that of singleton pregnancy, but some of the results are not as good as expected, because even in monochorionic pregnancies there could be discordant chromosomal abnormality, and different types of autosomal trisomy, even Turner syndrome, were also reported in the literature. If due to some reason or other you need to do amniocentesis, it's very important. You need to understand the chorionicity very confirmatively. If you know that it is a monochorionic pregnancy prior to 14 weeks, then of course you can tap one sac. Otherwise, it is better to tap both the sacs. If you go for chorionic villus sampling, for that matter, again, you are taking bits of tissue from the single placenta, and there is also a possibility assessment is not continued. So, as usual, the chromosomal abnormality, we need to look for structural abnormalities as well, and we go for anatomy scan that you always do somewhere between 19 to 20 weeks. Now, twins in general have little more structural abnormality than singletons. And in the twins itself, monozygotic has more on congenital abnormalities than the dizygotic. And if you take account of the monozygotic, most of them are monochorionic. So monochorionic pregnancies will have more of a structural abnormality. Incidentally, some of these abnormalities are midline in nature, like facial defect, then abdominal wall defect, holoprosencephaly, and so on. So, and most importantly, these monochorionic pregnancies are at risk of developing cardiac anomaly. So, whenever this anomaly scan is done, and it must be done by a person who is expert in it, but they should look into the cardiac part, the four chambers, and the important areas of the heart. It was found that if it is done properly, 80% of the cardiac abnormalities can be detected at this particular scan. So you don't need to do fetal echo always. So that is how one should follow. As a routine, it is believed that this patient should have ultrasonography from 16 weeks onwards, because development of abnormalities even before 16 weeks, even if it develops, is always severe and cannot be treated properly. So the first ultrasonography for detection of some of the abnormalities that I mentioned earlier should be started as early as 16 weeks and should be repeated every 2 weeks. So as such, if you find uncomplicated, repeat it every 2 weeks and continue it until delivery. And for the first 26 weeks, sorry, the primary purpose is to look for TTTS. And beyond that, the primary purpose is to look for the structural abnormality in addition to TAPS and growth restriction, either selective or concordance. In the 16 and 18 weeks, the idea is to not only to look for fetal biometry, also to look for deepest vertical pocket, what is there in the amniotic fluid, because that's the way we should assess whether she is suffering from, she is having TTTS babies or not. And at the same time, urinary bladder of the babies. And at the baseline idea about the umbilical artery Doppler velocity waveforms. From 20 weeks, as I said, detailed. So, yes, umbilical artery Doppler, and from 20 weeks, you need to do all the things, like even MCA PSB, because that is important to detect anemia. Means anemia, fetal anemia can be detected best by MCA PSB. Because of anemia, the blood viscosity will be less, and there will be peak velocity will be high, more than 1.5 million multiples of the median. And if there are any uncertainty or any confusion in the diagnosis, then you need to add few other factors, including Dachter's venous Doppler. So, 2 minutes. 1 minute. So this is the picture of TTTS. You look for the donor amniotic streak and the bladder. The diagnostic criteria that will be decided by the fetal medicine specialist. In the oligo, there will be less than 2 centimeter, and the polyhydramnios it will be more than 8 or more than 10 centimeter, depending on the duration of gestation. Besides that, one should look into the bladder volume and also other anomalies like hemodynamic and cardiac components. TAPS is diagnosed by MCA PSB, and the beauty of the TAPS is that it is because of anastomosis in the deep inside the placenta and by the minute vessels and by slow transfusion, and that is why in TAPS there is no discordant in amniotic fluid volume. Selective growth restriction started from 20 weeks onwards, continue to do it. The diagnostic criteria, usually screening criteria is more than 20% because the perinatal loss increases, but diagnostic criteria involves that if there is estimated fetal weight is less than 3rd percentile, yes, you call it. Besides that, one of the 2 criteria has to be present. So depending on that, you have 3 different types. One is the progressive type, second is, that's the best one, type 1. Type 2 is the absent or reversed in diastolic velocity, and third one is cyclical type or intermittent type. And the 1 or 2 slides. So if there are single fetal demises, then it's a problem. Now, single fetal demise occurs because of sudden acute hemodynamic changes that occurs, and that leads to low pressure and perfusion pressure of the surviving twin. That causes ischemic organ damage in the brain, and that is why the surviving twin is also at risk. There is no need to deliver the patient immediately. You try to identify what's the magnitude of fetal brain damage by doing MRI, which can identify the problem as early as 1 week. Ultrasonography takes more time. So, in conclusion, chorionicity is extremely important. You need to define it best by 14 weeks, and if not possible to manage by you better refer it to a fetal medicine expert having all the facilities. Thank you very much.
Thank you so much, sir, and delivering such an important talk in spite of you are not very comfortable with your throat, but twin pregnancy is such an important thing to diagnose earliest, and if not diagnosed early after 14 weeks, such an important point you highlighted, and telling the patients all the details and counseling about their things. So thank you so much for enumerating everything, and I think delegates, they have had their revision and updated also. Thank you so much. Our next speaker is none other than our own Dr. Geeta Sinani, and she needs no introduction, at least for the delegates from Bihar. Those who have come from outside, let me introduce her. She is beauty with brain of Bihar, and जैसा सब जानते हैं बड़े लोगों का छोटा introduction, so she had she needs introduction as just MS MRCOG, and at present she is heading the Department of Ops and Gynae at Patna Medical College Hospital, and everyone knows how she is keen to update herself in all the scientific things, and she is so keen to passing it down to her students. So over to you, Geeta Di, for your such an important talk, feto-maternal immune cross-talk, consequences and implications.
Thank you, and my time starts now. I'm very thankful to all the organizers for giving me an opportunity to speak on the topic of my choice, feto-maternal immune crosstalks, its consequences and implications. And I'm especially thankful
to Dr. Amita and Dr. Ranjana, my one-time favorite postgraduate residents, who permitted me to speak on this. There is an ongoing crosstalk at the feto-maternal interface. Basically, pregnancy is an immunologically balancing act in which the mother's immune system has to remain tolerant of paternal major histocompatibility antigens and yet maintain normal immune competence for defense against microorganisms. The consequences of aberrations in this normal feto-maternal crosstalks are recurrent pregnancy loss, recurrent implantation failure, fetal growth restriction, intrauterine fetal death, preterm birth, and preeclampsia. Recurrent pregnancy loss, everybody knows, is 3 or more miscarriages that occur before 20 weeks of pregnancy, and according to American Society, it is equal to 2 or more than 2. The incidence of RPL in couples of childbearing age is 5%. Recurrent implantation failure is 3 or more unsuccessful IVF cycles or failure of conception after the replacement of 10 or more good quality embryos. And this problem is now really important in this era of artificial reproductive techniques. The immunological cause of recurrent pregnancy loss or recurrent implantation failure could be either autoimmune or alloimmune. Autoimmune miscarriage is due to the antiphospholipid antibodies, especially the anticardiolipin antibody, the anti-beta-2 glycoprotein 1 antibody, and the lupus anticoagulant antibodies. Autoimmune antibodies, they basically kill the decidual or trophoblast cells, and these antibodies occur in 1/5 of patients with RPL. Alloimmune miscarriages is another category which is due to impairment of the maternal alloimmune response to paternally generated molecules on trophoblasts. Many RPL patients have cellular immune abnormalities, which is increased T helper to Th2 cell ratio, higher natural killer cell counts, and higher natural killer cell cytotoxicity, aberrant T regulatory cell and Th17 cell ratio. The cellular immunomodulators which are responsible, I'll just go briefly through them, are the T regulatory cells, which are critical mediators of tolerance. They become more numerous in pregnancy in response to the introduction of paternal antigens. This is a protective phenomenon. The Tregs produce protective interleukin 10, which appears to play a role in maintaining pregnancy. There are decreased numbers of peripheral blood and decidual T regulatory cells in females with preeclampsia compared with normal pregnancy subjects. The T helper cell type 17 is another one which produces the protective interleukin 17. The presence of Th17 may play a role in protecting the maternal fetal interface from microbes. Altered numbers of T helper 17 and or the ratio of Th17 to Tregs are associated with complications such as spontaneous miscarriage, preeclampsia, and preterm birth. HLA and altered expressions of HLA is also important. The placental trophoblast cells do not express the classical MHC class 1A isotypes HLA-A and HLA-B, and thankfully so. But they do express the atypical MHC class 1B isotypes HLA-E, HLA-F, HLA-G, which is assumed to prevent destruction by maternal NK cells. And similarly, the HLA-D region molecules are entirely repressed in trophoblast cells, and that is protective too. Now the natural killer cells, there's a lot of research now on these natural killer cells. Two types of natural killer cells are there, the uterine and the decidual, and peripheral blood natural killer cells. Basically, these are helpful cells because they cause trophoblast attraction and permit their invasion. And they're also responsible for decidual and placental angiogenesis. But excessive uterine natural killer cells are responsible for elevated cytotoxic activity and have been associated with pregnancy disorders such as implantation failure and miscarriage. The trophoblast macrophage crosstalk is another important phenomenon, and this is normally important for promoting normal placentation, implantation, vascular remodeling. There are two types, M1 and M2. M1 is inflammatory, M2 is anti-inflammatory. Aberrant macrophage numbers and activation, they play a role in pregnancy complications like preeclampsia, IUGR, and preterm birth. The dendritic cells are another helpful cells which abound at the feto-maternal interface, and they are critical for successful implantation and remodeling of vessels. They also promote immune tolerance during pregnancy, and they influence NK cell function and the cytokine profile in a favorable manner at the maternal fetal interface. We also have, apart from these cellular immunomodulators, we have the soluble immunomodulators during pregnancy. And basically these immunomodulators are either immunosuppressive or immunoregulatory molecules. Placenta produces human chorionic gonadotrophin in abundant amounts in early pregnancy. Progesterone, prostaglandin E2, and anti-inflammatory cytokines such as interleukin 10 and interleukin 4. IL-10 appears to stimulate production of protective HLA-G, which is again a protective molecule. Human chorionic gonadotrophin is so important, and that's why it is so abundant probably during early pregnancy, because it is key to establishing a local immune tolerant state and also through the cellular system of apoptosis. It modulates the Th1, Th2 balance, and T regulatory cells, which are helpful, are also attracted by HCG. Progesterone is another immunomodulator which has anti-inflammatory properties. It inhibits the transcription factor, nuclear factor K beta in the myometrial cells, and is responsible for promoting uterine quiescence by decreasing the production of the naughty interleukin 1 beta and interleukin 8. Estrogen is another immunomodulator which is produced by the feto-maternal unit. It inhibits the proliferation and cytotoxicity of NK cells. It promotes the differentiation of peripheral T regulatory cells, and estriol, which is E3, is capable of inhibiting activated B cells. There are other complement regulatory proteins also which are helpful. Then there is another one, soluble thymic stromal lymphopoietin, which is secreted by trophoblast cells, which stimulates the decidual dendritic cells to produce interleukin 10, which is protective. How to address aberrations of normal feto-maternal immune crosstalk? Immunotherapy is an option which is coming up in a big way, and there is a strong basis for providing this treatment to well-deserved patients who are eligible for treatment and who can afford it. To assess cellular immune abnormalities in patients with recurrent pregnancy loss, there are certain tests which we do. We assess the NK cell percentage, the NK cell cytotoxicity assays, Th1, Th2 cell ratios in peripheral blood. Basically, many research has shown that more than 12% of NK cells is related to bad pregnancy outcome. In other studies, this cutoff is 16 to 18%. We test for the NK cells in peripheral blood. We test for NK cell cytotoxicity and the NK cells in the endometrium and or decidua. Basically, this is done in a center of reproductive immunology all over the world. It is a very specialized center that you can do these tests in patients who are having recurrent pregnancy loss and recurrent implantation failure. Darbala Institute for Reproductive Immunology in USA is doing a lot of research on this and has got a lot of data, and the drugs they use for these alloimmune feto-maternal crosstalk aberrations is prednisolone, which is very helpful. They give it throughout pregnancy, intravenous immunoglobulin, hydroxychloroquine, tacrolimus, low-dose aspirin, and heparin. Prednisolone basically acts on the NK cells because the NK cells express glucocorticoid receptors. Now, there was a study in which one woman with significantly raised uterine NK cells had 17 miscarriages and was given 5 mg prednisolone preconceptually. She had a further 2 miscarriages, and then the dose of prednisolone was stepped up to 20 mg once a day, both preconceptually and in early pregnancy. And on this regime, she had a live birth. So there are many such studies which are coming up. And Dr. Darbala is doing a lot of research in reproductive immunology in USA. Another prospective study was carried out with 20 milligram prednisolone from day 1 to day 21 of the menstrual cycle, and this also demonstrated reduction in uterine NK cells in the pre-implantation endometrium, and that was beneficial for the recurrent miscarriage patient. There are safety consideration of steroids, but thankfully prednisolone is not transmitted across the feto-maternal interface to the fetus. It is only 10% of the drug reaches the fetus. So basically, when you are treating the mother, you give prednisolone. When you are treating the fetus, you give betamethasone or dexamethasone, which is 10 times more actively transferred across the placenta. There are concerns for possible intrauterine growth restriction and cleft palate, etc. from animal studies. But more recent studies with postnatal follow-up have not shown such complications with prednisolone use. The dose is, different workers advise different dose, like Turi et al. Started prednisone at a dose of 10 milligram per day, but Laskin prescribed prednisone at 0.8 milligram per kg per day for 4 weeks from confirmation of pregnancy by ultrasound, and then followed it up by 0.5 milligram per kg per day until delivery or fetal loss. The side effects of prednisolone, there is a big list for any drug side effect, but we are using so many other drugs so liberally, and they also have a huge number of side effects. Mood changes, weight gain, increased appetite, hypertension, hyperglycemia, avascular necrosis of the hip. The other option is intravenous immunoglobulin. In one report, 38 APS patients who had 3 or more early pregnancy miscarriages were included and received 300 milligram per kg of intravenous immunoglobulin every 3 weeks from the determination of pregnancy up till 16 to 17 weeks. And out of these 38 patients, 34 women, that is 89%, passed through the first trimester and 81% gave birth at term. Mechanism of action of intravenous immunoglobulin is by reducing autoantibodies, decrease NK cell activity, control secretion of cytokines, suppress the binding and activation of complement, increase apoptosis of activated cytotoxic lymphocytes, enhances the suppressive activity of the T regulatory cells. Many studies have shown that CD56 NK cells decrease in RPL women treated with intravenous immunoglobulin. In another research, NK cells were increased in pregnant and non-pregnant recurrent pregnancy loss women, and NK cells significantly decreased after the first IVIG treatment. The timing and dose of IVIG, IV intravenous immunoglobulin treatment, should be ideally started before conception, and this can only be possible in the scenario of an controlled ovarian hyperstimulation and ICSI cycle, and that improves the chance of live birth in primary recurrent pregnancy loss patients. In secondary recurrent pregnancy loss patients, intravenous immunoglobulin is usually given following embryo implantation, and then it has a higher success rate. It is to be given every 3 to 4 weeks because of its long half-life. It is expensive, 13,000 per dose, rupees 13,000 per dose. The side effects are also there, but thankfully only 5% patients have common side effects such as headache, myalgia, fever, nausea, vomiting. Anaphylactic reactions are only found in IgA deficient patients. So some centers are also testing for IgA deficiency before giving intravenous immunoglobulin. It is also associated with renal dysfunction, so you have to be on the lookout and check for renal problems before giving it. It also promotes blood hypercoagulability and may cause thrombosis. So that's why many centers are combining IVIG treatment with heparin and low-dose aspirin. Tacrolimus is another drug in the armamentarium. It is an immunosuppressive agent. It is widely used in Dr. Darbala's center. It is a macrolide antibiotic. T-cell activation is blocked and cytokine production is reduced by this. Tacrolimus improves pregnancy rates and definitely improves the outcome of recurrent implantation failure patients. The dose is 1 to 4 milligram of tacrolimus per day, and the price of 10 capsule varies from rupees 250 to 360. The side effect list is also there, but it is so. And another drug is hydroxychloroquine, which is also a vascular protective agent. It reduces hypercoagulability and endothelial cell dysfunction, and along with it, it also acts on inhibits antigen processing and thereby immune function. It is given in a dose of 400 milligram per day. Side effects are always there. The role of anticoagulants, all of us know, so I will rush through it. It is low-dose aspirin and heparin, which all of us already know and we are using. Side effects of anticoagulants. Intralipid infusion is not advocated because the live birth rate in women with recurrent pregnancy loss after intralipid treatment was similar to that after IVIG treatment. And intralipid treatment has a lot of side effects, so it is not advocated by advanced reproductive immunology centers. Thank you.
Thank you very Thank you very much, Dr. Geeta, for your very nice presentation.
It's all right.
And very informative talk. And this photo, I think Geeta will tell who this small child is. You are you. Thank you.
Thank you.
Thank you, Geeta. You have enumerated in a simple way the maternal immune system and how the pregnancy is rejected or protected. So thank you very much.
All the blessings of Anmula Di with Dr. Geeta.
Thank you so much for concluding it on time as well. We're just going to wait for 1 more minute and then get started, as the hall upstairs is also getting concluded in just 1 minute. As a protocol, it's the oration. And oration के समय बाकी सारे हॉल बंद होते हैं, लंच भी चालू नहीं होता है. So, yes.
May I request the chairpersons of the previous session and the speakers, Sukanto sir, Basu ma'am and Geeta ma'am, to kindly come for the photography. Ma'am, please.
We've just got a confirmation. The hall upstairs is also concluded. People are coming down. I would request... Can I request Dr. Mini Anand ma'am to please take the proceedings further for the oration?
सतीश चेक करो ना, आ रहा है.
To get started with the oration, can I request our chairpersons to please join us? We have Dr. Manju Gita Mishra, Dr. Alka Pandey, Dr. Abha Rani Sinha and Dr. Meena Samant to please join us as the chairpersons.
हाँ ऊपर जा रहा है आपको, ऊपर भी होगा आपको, नहीं लाइव चल रहा है. कुछ ऑडियो चेक कर लो सर, थोड़ा आप आपका चालू करो ना प्लीज, आप करो, मैं खाली ऑडियो चेक करता हूँ.
I must thank the organizers. पहले बुला लेते हैं. I thank the organizers for giving me this opportunity to chair this important oration, which is in the name of Professor M.P. John. So first of all, I call Dr. Dr. Pankaj Desai, please come to the dash, because Dr. Pankaj Desai is going to give this prestigious oration. Just to introduce Professor John. She was born at Ayamanan, Kerala on 29th October 1904. She qualified in medicine from Lady Hardinge Medical College, Delhi in 1930 with brilliant academic records. She had several feats in school and college examination. She won the most prestigious Hodgson Prize, annually awarded to most kind and sympathetic student to the patients. After serving several posts at Delhi, Ajmer, Lahore and Calcutta, she proceeded to the UK in 1937 and she obtained her membership of Royal College of OB-GYN within 6 months of arrival there. This was not an ordinary achievement for an Indian at that time. She became fellow of the college in 1954. On her return from India, she joined PMCH in 1939 and became professor and HOD in OB-GYN in 1953. She retired in 1960. It was her pioneering that she established the first antenatal care clinic in PMCH, which was to become the forerunner of the fundamentals of good obstetrics in the state and in the country. She has been a brilliant academician. She has been a brilliant academician, an astute clinician, an excellent surgeon, a gifted teacher, a kind and compassionate but strict disciplinary friend to her students and colleagues, and a towering personality whose head had the foresight into the future, a heart full of compassion, a mind full of philanthropy, and molded in one for the service of the society in which she lived her best and most fruitful years. We all share the fruits of the gifts that she possessed. Again, it is to her credit that she perceived the importance and need of a professional body to guide the future obstetricians and gynecologists collectively and individually to design and devise means and methods to fulfill the needs of the society. This led to the foundation of BOGS in 1958, and she was, which is now known as Patna Ops and Gynae Society, and she was unanimously elected to preside over this body for 2 consecutive years. Dr. Johan was the first lady gynecologist of Bihar and founder president of BOGS, Patna. After superannuation, she stayed on at Patna till 1968, and then she returned to her home in Kerala, where she engaged herself in service to the sick and the poor. She was one of the senior most members of the profession and was the moving spirit of several organizations. Apart from this, she was a human being par excellence and was a pious and religious lady. She finally proceeded for the heavenly abode in 22nd March 1991. Though she is not living physically, but she will live in the hearts of we obstetricians and gynecologists for all times to come. So,
it's my pleasure to introduce the speaker of today. I should say, to deliver the oration in name of such a illustrious person, Professor MP John, we have an equally accomplished orator, Dr. Pankaj Desai sir. Dr. Pankaj Desai sir is consultant Janani Hospital, Baroda. He has held many past positions like Dean of Students at Medical College, Baroda. He was Associate Professor at Unit Chief at Medical College, Baroda, and he has been the President of FOXI. And sir, we have called you many times for oration, and we are all always mesmerized to hear you. You have many awards to your credit. You have been awarded the Young Gynecologist Award by Asia Oceania Federation, the most outstanding young gynecologist by the Ethicon Fellowship, the Foxy Tamaskar National Award, the International Fellowship Award, the Best Publication Prize. There are so many. If I start telling, I think we'll be just finishing the whole time of oration with your awards. We have many international and professional recognitions, like visiting professional fellow in the University of Liverpool. You have been the Senior Vice President Foxy, President of Baroda Obs and Gynae Society, Chairman of Foxy Committee of Medical Disorders, Convener of Scientific Committee, and Chairman of Organizing Committee. You have been an editor and peer reviewer of many journals, and you have also been a member of editorial board of the current Obstetrics and Obs and Gynae, and you have so many orations. I think it's more than 500, sir, I know now. So I think you will definitely tell it was which oration every time in your presentation. You mention your oration. The whole audience is eager to hear to you, sir. So please, Meena, will you just say a few words?
No, I think we'll let sir begin. We are eager to hear.
We will start with a prayer. If the ladies and gentlemen there will allow me, can we, sir, start with a prayer, sir? All those lords of the last benches. Thank you, sir. Lead me from untruth to the truth. Lead me from darkness to light. Lead me from death to immortality. Om, peace, peace, peace. Thank you, Patna. You've always been very kind to me. Actually, I was surprised when Geeta Di entered. Such a busy and such a big person now, professor and head. But she always comes for last 20 years. Even in my AICOG lecture, I note her. Patna has been very kind to me. 39 years before, I took the podium for the first time in your city. 39 years before, many of you were not even born. Dr. Anmola Sinha oration on preeclampsia emerging trends, thanks to Abha Madam, in December 2018. Then first lecture, December 89, 1995, 2000, 2001, 2004, 2020, and 2001 first paper I won presented in 1989, which got me the best paper prize. You people have been very kind to me. Sometimes I feel, what did I do in the previous birth to deserve so much love and affection? It is your kindness and not mine. The topic of oration that we are going to discuss today is from ordinary to extraordinary you. Extraordinary people don't do extraordinary things, but they do ordinary things in an extraordinary way. If you think you are ordinary and you start doing things extraordinarily, you become extraordinary. We are going to cross-talk today in you and me. As Geeta Di was talking, about the crosstalk between the blastocyst and the mother. Most of the times I am aware, I am conscious that my lecture becomes useful to you from the next day. This oration will be of use to you from today, right now, if you so desire, and stop talking. मुझसे भी कहो ना मैडम, किसकी गॉसिप चल रही है मैडम? डॉटर इन लॉ की किसकी चल रही? नहीं, थैंक यू. So from ordinary, would you like to become extraordinary? Philosophy and actions that have helped millions of people throughout the world, and therefore I see no reason why it should not help you. What way you are ordinary? Yesterday one of the presidents ingoing or outcoming or somebody said, we want to be like Mumbai society. Why? Be Patna society. Be extraordinary. Narendra Modi didn't say that I want to be a Jawaharlal Nehru or somebody, or say be a Narendra Modi, ordinary man, doing extraordinary things. This is not a self-help session, because self-help sessions help you to become materially more successful. They help you to earn far more money, get a bigger name and fame, get a higher post, get more and more promotions. This will help you to do nothing of this. So if you are expecting that, thankfully, the organizers have kept the doors open. I will not mind you leaving. But then what will it do? It will help you to be more khush, happy. It will help you to be more joyful. Khushi and joy are two different things. Today I am not speaking on anything academics. I have gone right up to electrons and protons in this society and explaining to you so many problems in obstetrics. Today I am going to speak of non-academic things. This lecture helps you to be more joyful. Joy comes from within. There is no explanation. Khushi, when a beautiful girl passes, Sukantoda becomes very khushiful. But when I see him khushi, I become joyful. There is no reason. It helps you to be more at peace. It helps you to be more satisfied. बैंक बैलेंस नहीं बढ़ेगा, ये सब होगा for sure. Very important, when after this oration, if you implement it, when somebody comes and meets you, that person will feel, I have come home. Reaching home does not solve your problems, but gives you a peace and get recharged to face the problems anew. Will somebody give her some place to sit? She is our senior member. Reaching home. I was telling Sukantoda, got a phone call from a common friend, senior, few months before he had passed away. His son rang up. He is also a gynecologist. And his son said, sir, you talk on the mobile with the family. We are putting you on speaker mode. 10 minutes after his death, his body was still there. The entire family is very hurt. Will you please talk? I talked. And afterwards the daughter-in-law said, Dada, I felt we reached home. This will happen to you. गीता दी को मिले तो लगता है घर पहुंचे. अनमोला जी को मिले, एक वंडरफुल आउटगोइंग प्रेसिडेंट को मिले, मीना सामंत को, घर पहुंचे. What bigger an achievement than this? I will tell you a story. Yesterday, last evening also I told you a story. This is another story. I am age of a grandfather. My children have decided by design not to go in for children, so I will not become a biologically grandfather. Therefore, they are anti-natalists. They don't want, fine, that is very modern thinking and I have nothing to say. Their life. But I am of a grandfather's age and I love to tell stories because stories are effective, skillful and powerful ways to convey your message. Long, long ago, there was a farmer. He had 2 buckets. One intact bucket and one leaking bucket. Ashamed of its flaw, that the leaking bucket was always making its way back home empty, the bucket began to feel depressed and became less and less talkative. Like this. बातें नहीं करते थे, चुप हो गई, शांत हो गई. अभी कितने लोगों को बात करनी है? उसको बात नहीं करनी थी. बहुओं के बारे में बात करनी है, सास के बारे में बात करनी है. Observing this, one day the farmer had a conversation with these buckets. He told the imperfect bucket, have you noticed that the beautiful flowers have sprung up upon your side of the path, but on the other side there is nothing but earth and stones? See this. This was the path on which he was carrying the leaking bucket, and this is the path where he carried the intact bucket. Are you getting the message? Yes. I planted seeds on your side, and every day you watered them when we were returning home. Over the last few years, I have been picking some of these flowers to decorate my house, and people like us from India will say, and offer to God. So don't try to be perfect, all of you. Perfection is very boring. Please. Perfection is very boring. It is useless. Not for us. See this template. Gita Devi gives lectures so often, so she knows. This is a perfect template, isn't it? Perfect. Can you read anything? Nothing. Now I am making it imperfect. Now can you read? There is one black and there is some white and something this. Imperfection is a very good thing. I am selling a different perspective. Orations have to not be from the book. They have to come out with something path-breaking. Don't give an oration. Many times people give me topics of oration. I point blank politely refuse. That is not the way orations are given. We are always programmed to be negative towards flaws right from our childhood days. First rank laane ka, first rank laane ka, first rank laane ka. I never stood first in my class. Never. My dada always stood first in his class. Convert negativity to positivity. That is what you will have to do. Just look around yourself. Your most beautiful happenings and individuals are imperfect. Check. Dekhna. See your father, see your mother, see your teachers. They were all imperfect people. Perfection is very boring and constricting. Swami Vivekananda, Dr. Richard Feynman, one was a Jnani, another was a Vijnani. Extremely respected, extremely valued. None was perfect. We know their imperfections. Swamiji himself said, Richard Feynman also himself said, whatever drawbacks I have. But both are respected after years that they have left. He got 2 Nobel Prize, Richard Feynman. And even more than after 100 years of his passing, he still continues to inspire even the Prime Minister of this country. Like the crack in the bucket, each defect is at the same time a virtue. We always gain something with each loss. Have you at any time thought about the blessings of diabetes mellitus. You always look up like that, diabetes mellitus. For most of you, it is a flaw. But for me, I had a ma who had PCOS, so I am likely to develop a diabetes someday. I was aware of it. I was alert about it. And I tell to my patients that this is a golden opportunity to become healthy. Let us acknowledge the flaws of perfection. When you were not having diabetes, कुछ भी खा रहे थे, कुछ भी करते रहते थे. Now, we are conscious of what we eat. I am still not diabetic. Still, 6 sessions of exercises per week. I dance every Tuesdays and Saturdays. Zumba dance, अकेले में शर्म लगती है. पर डांस करता हूं मैं for exercises, and I sleep peacefully for 6 to 8 hours. There is a monk who tells, not real term monk, sleep is a waste of time. Nonsense. God would not have created sleep if he would it not a waste of time. Sex should be debarred. He created sex. It is how you handle it. Don't try to be a perfectionist. Perfection is boring. Just look at this when you have become angry like this. Anmola madam also has, our Abha madam has also chaired the department. Gita madam is chairing now. Shanti Roy madam I saw, I think. She has also chaired the department. She must have got angry. 100% as administrator, I also got angry. All angers arise out of our intolerance to imperfection. Mark this. ऐसा क्यों किया? ऐसा नहीं करना चाहिए था. क्यों नहीं करना चाहिए? Because perfection means ऐसा नहीं करना चाहिए था. ऐसा नहीं होना चाहिए. एक परफोरेशन यूट्रस में हो गया यार. Perforate the uterus. We teachers are there to suture it. Why are you afraid? सीखोगे कब? When will you learn? If somebody tells I never done perforation in my life, either that person is telling lies or has not done a single DNC. So you are teaching this. You are teaching imperfection. Be comfortable with imperfection. All angers arise out of intolerance to imperfection. Just recollect the individuals or situations that made you angry. What made you lose your cool? Because something happened that was not to your expectation. Basically, your expectations are that of perfection. And that is where comes in wabi sabi. Accepting things as they are. ठीक है यार, सब ठीक है, बराबर है, अच्छा है. How many times are you ready to accept things as they are? दाल में नमक थोड़ा ज्यादा पड़ गया, ठीक है यार, रोज तो अच्छा पड़ता है. 100,000 mothers, I don't want you to ignore it, but 100,000 mothers are coming out fine. 100 are going away. We are fighting for that. But don't do this for those 100 mothers. We are working on it. It is imperfection. Even in foreign countries, mothers die in pregnancy. Perfection means zero. This is a beautiful, practical Japanese philosophy which gives you instant peace and evolves you by miles. Try to evolve. Growth is passive. It will occur. Development is active. Evolve. As soon as you are comfortable with imperfections, yours and that of the world, see how instantly happy you become. कोई बात नहीं. My flight was the previous week 6 hours late. ठीक है यार, क्या फर्क पड़ता है? And people were fighting. That Indigo lady, अरे ठीक है यार, पहुंचाएगा ना घर? हाँ सर, घर पहुंचाऊंगा. बस है यार. If you are comfortable with imperfection, your anger has no business to be there. If it arises, think of wabi sabi. Immediately you will become like this. From anger to calm. So to be extraordinary, be comfortable with imperfections. And an extraordinary mantra for that, very powerful mantra, no problem. No problem. मैडम राउंड में दिखा दिया पेशेंट, मैडम ये पेशेंट एब्डोमेन बस्ट हो गया, नो प्रॉब्लम, वी विल टेक केयर ऑफ इट. हमको आता है, उसको इन्फेक्शन हो सकता है, इट्स ओके, नो प्रॉब्लम. यू डोंट डेप्रिकेट योरसेल्फ. सूचर करेंगे ना, उसको इग्नोर नहीं करेंगे. आपने टाइम सर पकड़ा, वो नहीं बोल रहे हैं मैडम पीपीएच हो गया, कोई बात नहीं, देखते नहीं, होने दो नहीं बोला, मैं होने दो नहीं बोला, नो प्रॉब्लम. दैट इज एन एस्केपिस्ट एटीट्यूड. No problem. And that will evolve you and see how peace it generates in there. कोई बात नहीं, चलो देखते हैं क्या है, चलो देखते हैं. डर जाते हैं, आप भी डर जाते हैं. पुलिस नोटिस आती है कोर्ट से, हाँ, अरे नो प्रॉब्लम यार, लॉयर्स को पैसे क्यों देना है, देते हैं, इसके लिए तो देते हैं, नो प्रॉब्लम. One more, be extraordinary, one more tenet. I have a timer here, I will finish in time. Never explain yourself to anyone. This is not what I said. This is what APJ Abdul Kalam said. Resist temptation to make excuses or defend yourself to others. No need. Just do it. Show results. Show results. बात नहीं करता मैं. Overawe people not by empty words. मैंने तो ये कर दिया, वो कर दिया, ये है मेरा, यो है, कुछ नहीं चाहिए, रिजल्ट दिखाओ, ठोक दो. I stay in Dandiya Bazaar. It is the heart of a city where nobody would like to stay in. I live there. I have a 7,500 square feet area there. 5,000 is the hospital, 2,500 I stay. And from there I review papers of 3 of our 5 topmost journals of the world. Right now, today, when I was coming, I got a paper from American Journal of Obstetrics and Gynecology, जिसके एक रेफरेंस के लिए आप कितना बोलते हैं? अरे मेरा एक रेफरेंस आ गया उधर. इंडियन जर्नल के लिए बोलते हैं आप. I sit in Dandiya Bazaar and review 3 of the 5 journals. Show results. Show results. Coming from a small city like Baroda, and rose to become the president of Foxy. With pure academics, no politics possible. Show results. Overawe them by stunning, jaw-dropping results. Arey, Sukanto, you did this? Oh. Make people jealous. It is the ultimate acceptance of your good work and superiority. You are not jealous of this, are you? You are not jealous of that chair, are you? You are jealous of people who are superior to you. ये कैसे आगे निकल गया? When we were young, अरे सुकांतो दा वो लड़की को कैसे impress कर गया? That means सुकांतो दा is so handsome. राजेंद्र परदेसी पे वो लड़की मरती है यार, हमारे सामने तो देखती भी नहीं है. अरे परदेसी ऐसा ही है, फिर चालू, परदेसी ऐसा ही है, परदेसी ऐसा है, उसमें jealousy है. You are accepting that परदेसी is superior. I told you this is an unconventional oration. It will shatter your ideas. If someone is jealous of you, he or she is accepting your good work and superiority. Be happy about it. आप में कुछ है, आप में कुछ है, इसलिए आपको, yeah, you are not jealous of substandard people who are less than you. Are you jealous of your so many others whom you are leading today? No. If people are jealous, you are alive. If people are jealous of you, you are alive. Lest you are walking dead bodies. Hey Ram बोलना है, पहले बोल दो. One more extraordinary point. The mantra of peace. Very easy. ये कल भी आप लगा सकते हैं, आज से यूज कर सकते हैं. No problem, you can yawn. If my mind can remain balanced even in crisis, think this. If I can sleep soundly and laugh heartily, मैडम चाय ले आएंगे कोई मैडम के लिए? If my mind can remain balanced even in crisis, remember this, these are very important words. Remember in your life. If I can sleep soundly and laugh heartily. Can you laugh heartily? कैसे हंसते हैं हम? ऐसा हंसने की ताकत है क्या? If I feel hungry and if I get thirsty, if I don't have a major illness or a big debt on my head, I have no debt for last 25 years. If one house under the roof of which I can eat my daily dal roti with my family, मैं बोलूं मैडम? मैं बोलूं? Thank you. Then thank you, God. You have given me much more than I deserve. And at the last moment of my life, when our incoming Vice President will come to mourn my death, that is the time, if on the last moment of my life, if all this stays, I will exclaim, what a fun it was to live this life. Yeah, मजा आ गई जिंदगी जीने की. सोचना. Now I am coming to the last part in the next 10 minutes, and it is the most difficult part because you have programmed yourself very heavily, just like not being tolerant to imperfection. This is also an amazing intolerance, and this has happened today in Gitadi's lecture itself, and I will show you how. Thomas Fuller, 1710 to 1790, good readers must be knowing this. He was an enslaved man. Madam, really disturb होता है. मैं मजाक कर रहा था. Please, हो सके तो. He was an enslaved man who earned renown for, at the end of his life, for his ability to calculate numbers in his head. This man has said, all things are difficult before they are easy. I am going to take you to something difficult now. From your mortality to immortality. सबको अमर होना है. पर मालूम है, death, taxes, and one time corona were inevitable. They are bound to happen. Now, cyber fraud. Death, taxes, and cyber fraud are 100% certain. See this. Posts, positions, status, fame, and such mundane achievements are finite. Invest in infinite activities that make you happy from within. Social media is a massive delusion creating platform. उधर excellent के सिवा कोई भी adjective use नहीं किया जाता. Idiotic dance, most nonsense dress, excellent, 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 excellent. और कुछ होता ही नहीं है उधर. Keep your feet firmly on ground and invest in activities that will last beyond you. The extraordinary you will respect the power of time. I saw a film nearly 10 years before, me and my wife. That time we used to see in the theater. It was a Marathi film. Thankfully, I can speak, read, and understand 11 to 12 languages, and that is God's grace. I can understand Marathi. And the title was Nata Samrat. Nana Patekar had acted in this film. And when we came out of the film, my wife Meera, she said, Pardesi sir must have enjoyed it in Marathi. My wife said, Nana should stop acting after this film. That is the climax he had gone to. And what was the message there? Marathi को translate किया है. नाम काल का भक्ष्य है. काल मतलब समय. नाम मतलब name. Time is a humongous consumer of name. It ruthlessly eats up your name. 100%. How many of you know the name of your great-great-great-grandfather? Nobody. I don't even know of my great-grandfather. How many of your children, grandchildren, and great-grandchildren are going to remember your name? भूल जाओ. मृग जड़ के पीछे मत भागो. नहीं होने वाला है ये. I will give you 2 examples. How many of you can identify these 2 people? Both were vice presidents of India. And this gentleman here actually inaugurated our Bhubaneswar AICOG, where I was installed as a vice president. That time there was no installed as a vice president. You would just go and sit. He inaugurated AICOG. आपको किसी को मालूम नहीं कहाँ है ये? आगे पीछे उनकी सरकारें चलती थी, गाड़ियां भागती थी, पुलिस सल्यूट करते थे. we were not allowed to sit on the podium because the vice president is coming to inaugurate. कहाँ है ये? कौन है? घर जाके पता लगाना. आपकी बहू को पूछना इनके साथ जिसके बारे में बातें करते हैं. But the message is important. नाम काळ का भक्ष्य है. नाव काळाचा भक्ष्य आहे. That is the original. Time is a humongous consumer of name. It ruthlessly devours your name. Don't aim for name or fame. They just don't matter. What lives on, surely lives on, are those small parts of you which all who come in touch with you will be taking away from you. Be careful what they carry from you. They will carry your fragrance, your ideas, your virtues, but not by name. I was sitting there when Geetadi was speaking on crosstalk. 16 years before, I have given this lecture in this house. Dada, your Golden Jubilee oration of Calcutta, of Bengal Society, I have given on this topic in 2007, 17 years before, the same topic. That idea has gone. You don't know Pankaj Desai. You don't know Pankaj Desai was teaching this originally. Today Geetadi has taught. Tomorrow someone else. Day after tomorrow still someone else. That idea which has gone, that idea is immortal. A mother gets benefited. NK cells she is talking of. She is talking of corticosteroids. I have listened to you. I have listened to you attentively. I lambasted them. Both these compounds I had lambasted for recurrent pregnancy loss or preeclampsia. She has brought in new ideas. That idea is immortal. Who gave you the idea? We don't know. Why are you sitting like this today? Why is your response like this today? We don't know. It must have come from somebody. If you have lived a bad life, your generations to follow will just wave your name off. My Dada's brother, Dada means not elder brother, in our area of India, Dada is father's father. Nobody remembers him, but everyone remembers my Dadaji. Because in those days there were child widows, and he used to go to the Shroff's house, take the books whose name the debt was, he used to tear off and take it on himself. I have never seen my Dadaji. And then took the debt on his head. He became so much indebted that had to go to South Africa. And while he was coming back, he caught yellow fever, died on the high seas, and his body was not even cremated, was thrown inside the sea, never to return. But his ideas, the pain, the entire family, I've seen my children also. When you see us suffering, the way they suffer, the way you do like this, हम है ना, ऐसा हो जाता है. कहाँ से आया वो? मेरा है. वो दादाजी से आया. कौन दादाजी आपको पता भी नहीं है, मैंने भी नहीं देखा उनको. My father was like that. So many raids of income tax, means money of banks, he has got lifted. क्यों? He never said that this is because of Dayarji Desai. He is Dayabai Desai, I am Pankaj Dayabai Desai. Dayabai Desai did it. But it comes from Dayarji Desai. So ideas which you give, they are immortal. They will carry, be careful what they carry from you, because they will carry your fragrance, your ideas, your virtues. You may be alive, you may not be alive. Rahe na rahe hum, mehka karenge. Flowers spreading fragrance after they are crushed. Flowers don't spread fragrance without that. Get crushed, no problem. The immortality of the extraordinary you when you become extraordinary will know. I also know. What will never die is the idea that you gave to others. What will never die is the type of life that you lived. Let us live a valued life, others will follow, and let us live virtuous ideas which will continue to touch lives for generations to follow. A student came few days before who is present doing internship, post-graduation in the department where I worked for 30 years, and she said, "Sir, still they are doing this in the clinical meeting and this is how we have to present." I was smiling. This is what I started. A valued discussion. Ideas continue. It is exactly 38 minutes and 52 seconds. The last film, look at it very carefully. That sums up everything, and my tribute to Dr. John. I have worked on every slide. I have been working on this oration for last 1.5 months. Even in this film which you see, every slide, every scene, every message, every color, I have worked on. And therefore, when that lady tried to disturb me, I had to cut her short. Though so much hard work has gone in, I take my job very seriously. Sampath Kumari was telling me today that I have to come in April there. I said, I'll come, but give me a difficult topic. Of all the topics which I have listened, sorry, I am repeating her name again and again, hers was the most difficult topic which preceded my lecture, my oration. So this is what I am going to, this is what the film will summarize. Just sit back, relax, and watch. Extraordinary you. Thank you very much.
So thank you very much for the wonderful, wonderful oration. We are indebted to you for accepting our invitation to be here once again with us. We remember you've given many emotional orations before as well. You've got tears in our eyes before as well. It was wonderful.
So now I invite all the chairpersons to kindly felicitate our orator, Dr. Pankaj Desai. Sir, your idea may remain infinite and immortal, as you say, and that is what we wish from POGS.
just to let everybody know, immediately after this, we're just going to be going ahead with the panel discussion, followed by Dr. Pragya Mishra's talk. I would like to thank Dr. Pragya Mishra for accommodating, because Dr. Alka Kute madam has a flight to catch, and being from the host from Patna, it's obvious that pyar to hai hi to. Thank you so much. Since we would like to still keep it on time, all right, let's get started with the panel. All right, can I request our panelist, Dr. Alka Kute madam, to please join us on the stage, along with Dr. Sharika Roy, our expert, Dr. Kumkum Sinha. Can I also request our panelists to please join us, Dr. Jyoti Agarwal, Dr. Anamika Pandey, Dr. Kamini Chaudhary, Dr. Ritu Singh, Dr. Shabnam Varsi, Dr. Naz Ahmed, Dr. Prabhati Kesri, Dr. Nimisha Agarwal, and Dr. Sudvita Sinha. छोड़िए मैडम का फ्लाइट है ना इसलिए A kind request for all to please settle down.
So I think I should thank Dr. Pragya Mishra and of course Patna OBGYN Society for giving me the chance, as I have tried and I tell you within half an hour or 30 to 40 minutes. So I think all the panelists are very well known to you. So we'll save time rather without introduction of the panelists. आप ऐसा बैठ सकते हो, मतलब आपके तरफ मेरी पीठ हो रही, ऐसा कोई जॉइन हो सकते, इसको इधर साइड करके थोड़ा सा, I should be able to see you or you can see. Okay, थोड़ा सा शिफ्ट हो जाओ. So let us start with the panel. After the wonderful lecture of our great, I should say, the philosopher, POGSCON, and our guide, Dr. Pankaj Desai sir. Actually, it's very difficult to deliver any lecture after a lecture given by Dr. Pankaj Desai sir. But again, keeping the time, we have to go up to the program, as per the program. So we'll start with the panel discussion. And of course, this is a medico-legal panel discussion. The idea behind that is not to create terror or any fear regarding practice, but these are the issues which we come across during our day-to-day clinical practice. And I think instead of getting afraid of our practice or adapting defensive practice, we should start learning our laws that govern our day-to-day practice. Because we can't live obstetrics, because we have learned lot of obstetrics. We have spent so much of our duration of our life in learning obstetrics. So we should never go for defensive practice. On the contrary, we should know the laws that govern our day-to-day practice so that we can protect ourselves, we can prevent the litigations against us. So the plus side of the panel, please give chair to Dr. our expert, Nupur Sinha. So the panelists are there, and I welcome our expert, Dr. Nupur Sinha, who will be expert for this panel. Friends, let me thank organizing committee to give me chance to participate in this wonderful Patna OBGYN conference. Secondly, we all of us know that there are great leaders. They don't tell you what to do, they show you how it is done. So Dr. Pankaj Desai, a leader like Dr. Pankaj Desai and many great leaders, they are amongst us. They not only tell us what to do, but tell us how to do. So how to do is more important than what to do, because that solves our problem, that solves our issues. So these are the panelists, expert panelists, and of course the expert, Dr. Nupur Sinha madam, who will be solving our issues by telling how it should be done. So let us go. I request, please keep silence so that we can finish it in time. So the first case goes to, and the panel, means anybody can answer the question. I will not direct question to any panelist. Whoever want to answer, they can start answering. First case, this is regarding obstetric hemorrhage in Rh negative mother. 24-year-old primary gravida with a Rh negative blood group presented in labor at 38 weeks of pregnancy. Her hemoglobin was 9.8 gram%. It was otherwise uneventful pregnancy. Labor was prolonged and she had to undergo emergency LSCS due to fetal distress. Intraoperative, patient went into atonic PPH. Blood was not available immediately, so it could not be transfused during intraoperatively, because no cross match was done. Bleeding continued and eventually she landed up in an obstetric hysterectomy. Blood could not be given as it was not arranged, and she continued bleeding. There was hypotension and OH had to be done. So what are the medico-legal issues or liability in this case? The obstetrician, treating obstetrician will have to face. This is a question anybody can answer.
Yes, the medical legal problems in this case is that if it is a Rh negative, in all cases we have to arrange blood beforehand.
So the issue number one is arrange blood in Rh negative patient irrespective of type of patient.
Yeah, okay, yeah. We have to arrange blood beforehand, and so that even at least 2 units, so that in any eventuality, and especially when the hemoglobin is 9 grams, there are more chances of atonic PPH.
Okay, so the first and important issue, madam has already explained, blood was not arranged. Secondly, we had to counsel the patient. There can be a chance of, though it is a unusual or simple pregnancy without any high risk factor, but we know labor, we can't anticipate few things. It is beyond our imagination. So because she was Rh negative blood group, we had to explain that, keep everything ready, we may not need it, so arrange it. Because हमारे patient का सवाल क्या रहता है, blood लाना पड़ेगा क्या, blood देना पड़ेगा क्या, खून लाना है क्या, so many questions they ask us. So our prime duty to explain her, though she is like a normal or usual patient without any high risk factor, but labor we can't anticipate, even section, sometimes we have to face emergencies. So counseling, communication and keeping blood 1 point ready, even though she was the primary gravida and there was no associated comorbidity factor. Okay, this was the simple case. So
and
we started.
There was a risk factor.
Yeah. So always anticipate complications, be prepared always. Blood has to be reserved for Rh negative mother. Consent for obstetric hysterectomy has to be taken in writing. Now this is very important question. Whose consent? Whose consent? Is it required?
Consent of the patient has to be taken beforehand, before any procedure, and it has to be written and signed by the doctor and the patient as well. And if you have any witness also, that also we have to take the signature of the witness.
Okay.
And it should be done beforehand.
Nupur madam, can you answer this question? She said consent of the mother.
The patient is already on the table and you need that blood. So the guardian, the husband, they can be taken into confidence and they have to write their relationship to the patient.
Okay, so there are two issues. There are two issues as rightly explained by Dr. Nupur madam. First thing, in emergency, consent is not required. Emergency treatment, we can go ahead without consent.
with the
But-
best interest of the patient, we can go forward.
Yeah, but the relatives are there outside the OT who are waiting for the result of the patient. लड़का हुआ कि लड़की हुई, patient कैसा है, so many questions asked to us. So we can just inform the relatives, but take in return of the guardian or whoever is there. Mother-in-law can be there, mother can be there. Take their written information, consent that we have explained that she will need obstetric hysterectomy because she is on OT table, and consent of the patient on OT table is not valid even though she responds to our questions, but her signature cannot be taken because she is under anesthesia, she is on OT table. Consent in the case of planned something we have to take of the patient, but when patient is already on table, we have to inform to the patient's relative nearby, means who are waiting outside, inform them, take their written signature that we are going with obstetric hysterectomy to save the life of the patient. But at times, if nobody is there, the doctor and the in charge of the hospital can go ahead even without a consent. Sometimes the husband is only there and he has gone to bring blood. Actually, bringing blood is the responsibility of the hospital. They have to arrange everything. But suppose by chance somebody is sent with the husband, and at times you have to go ahead with obstetric hysterectomy to save the life of the patient. Then at times you can go ahead thinking for the betterment of the patient with good trust, with good faith, and of course the in charge of the hospital. So these things are very issues, very important. Otherwise patient, we can lose the patient if we wait for some time, somebody to sign the information form.
Ma'am, and it's always a good practice not to send the husband for such
Yeah,
things.
correct. That
He
we
should be
discussed
there
actually.
outside for consent.
Yes,
So
we have to send somebody with the husband. Never send husband or
Never
close
send
relative.
husband.
Even we can send a staff to nearby blood bank. And the first issue, very important issue, was to arrange blood. The doctor did not arrange the blood, though the patient belonged to RH negative precious blood group. So arranging
The
blood.
hemoglobin was also low. If the hemoglobin
Yeah, and hemoglobin 9 gram is very low, so she should have anticipated there can be atonic PPH even in primary gravida, even without comorbidity. So all these things are very important, and others correctly point out by you, we should not send closest relative like husband. On the contrary, it is our duty to bring the blood. लेकिन sometimes हम good faith में नहीं आप जाओ इसके साथ आपको भेजते हैं. We should never do, especially when the patient may need obstetric hysterectomy because she had atonic PPH.
Madam, can I add something?
Yes, yes.
I think when the patient had come at 38 weeks, it is the responsibility of the doctor to take the blood and do the blood, investigate her group. This can't be missed. You're going for a group is known.
Blood group is known. Already she knows that it is RH negative. That's why we have
so that
pointed out
had
this.
to be arranged. That will also come into medical legal purview.
Yes, yes.
That
That
the
was
blood
the
was not
important medical legal issue. She should have arranged blood in advance. Even when the patient got admitted, that time only because she may require cesarean section, primary patient. Even though everything is going as per the partogram, but fetal distress can be there. She may need emergency hysterectomy, cesarean section.
arrangement of RH negative donors we do in the antenatal period. Probably she was a unbooked case, we don't know.
No, she is a book case.
Book case. So first of all, correction of anemia, that would have been done because she reached 38 weeks with a HB of 9. So failure
So
on
there
the
are
part
many
of the
issues.
antenatal care.
Yes, correct.
And
Many
second,
prolonged labor should also be avoided in RH negative patient.
Yes. So there are many issues like sometimes what happens in primary gravida, they come to their maternal place near 8 months, near 9 months. So that time there is no chance for the treating obstetrician to correct the anemia. So this must be like that only. She came during 9 months. हमारे घर में रहता ना एक तो 7वें महीने में भेजो नहीं तो 9th महीने में भेजो बहुत सारे customs are there in many this thing. So sometimes they are not sent when they are at 7 months. That time she comes to her maternal place when the 9th month is running. So it can happen that she must have arrived to the obstetrician when it was 9 gram hemoglobin. But that time also she could have transfused, or at times she should have, at least she should have arranged 1 pint of RH negative blood. Because
Madam,
it is the usual practice, yeah.
Madam, patient and her persons and with the doctor इन लोग के साथ sitting होता है, counseling होता है. They should be told from before she may need blood. You are RH negative.
Yeah, that
you're a
issue we
special
discussed.
case.
That issue we
That
discussed.
is the taking the patient and the doctors into confidence, and this wouldn't go this unheeded.
So
it
important
is a
thing-
very important part of antenatal care.
Yes. So important point, we already discussed counseling, communication beforehand when the patient got admitted or during her last visit only, when she had come to in the last 7 days or last 3 days of the this pregnancy period. So this was very important. 2-3 things we have already discussed. There is shortage of time, so we'll go up to the second case so that we can finish at least 4 or 5 cases. Next question is, will you transfer or refer a sick or very serious patient? The patient is sick, very serious. Anybody can answer.
Yes, I will transfer when the patient condition is beyond the level of my competency or the condition of the patient require multi-speciality care. But before transferring, we should assure that the patient condition, whatever, we should try to improve the condition, arrange the ambulance which has full equipment with a trained staff or a doctor himself or herself that can support her life in the ambulance.
Okay, so you have answered one part of the transfer. Before that, what part we need to discuss before transferring the patient?
First, we'll assess the patient.
We should stabilize
see the condition. Since this patient was operated in my hospital.
This is the second case. This is not related to first case.
We should stabilize, then
After
shift the
surgery.
patient.
That she discussed. That we have to stabilize the
We'll
patient.
take into confidence the patient's attendant, explain to the patient attendant that we don't have the facilities, resources and manpower to deal with the situation right now in the current hospital.
Yes.
So we need to transfer her. At the same time, we'll explain to them that the cause of the condition can be either surgery related or it may not be surgery related, and take proper communication and
So the
documentation of the
second point
communication.
you have discussed
document
communication, the need of transfer, why we are transferring the patient. Any more points?
And whether the patient's attendants want to transfer the patient or not. If they are not willing and if they are not ready, then we have to document it, take their consent, and then make arrangements for the transfer. Then we'll, wherever we are transferring, we need to communicate to the referring center also, which doctor we
So
are
third
transferring,
point,
communicate with them,
Third
prepare,
point,
tell them a
contact,
summary
yes.
of the case.
Yes. So third point, contact to the where we are going to transfer. Any more?
Ma'am, documentation, whatever we have, interference we have done, and then transfer in to the higher facility after informing them.
That madam, we have discussed. She has already.
Madam,
Any
one
more
of our
point?
team member should ideally, in good faith, should accompany the
Correct.
patient.
There is a landmark judgment on this particular point. Some patient was transferred to a tertiary care. There was ambulance behind that. There was car behind that ambulance. Expert was sitting in the car, and there was some demise on the way. There was a court case. The expert person said, I was there with the patient, but in where? In the car. That car was chasing the ambulance. So the case went against the doctor because he or she should have accompanied with the patient to see that whether the laryngeal tube is on the way, whether it got out expelled. So there was problem of hypoxia. Patient died during the transfer. So the how to transfer is very important. Any point, madam, you want to add, expert?
Madam, is it necessary for a doctor to accompany the paramedicals and also not a specialist but a junior doctor also can be put on the ambulance to accompany this thing? It is not that it will be death and the senior person will say, okay, I was there like that.
No question of senior, competent person. It's not a senior or
person
junior,
and
competent
paramedical
person.
staff.
Yeah. Any more point? Yes.
We should first stabilize, then shift.
That
the
she
patient.
told. That point is over. Stabilize. Inform the person or the hospital where we are going to transfer. Documentation.
Also,
Madam said anybody but competent person. Yes.
During the course of transfer, we should go for the continuous monitoring of the patient.
Yeah, that we explained by
that we have explained.
competent person.
Ma'am, also guide the patient's attendant with that when they reach the particular center, where to go, how to go about, whom to contact, which doctor to get themselves admitted to.
Okay, that point actually is, we know that like a well-known hospital, government medical college, Patna government medical college, everybody knows where to go. Okay. I think a bill settlement issue is a big issue. We will not discuss here because there are issues. Patient was not transferred or transferred late due to bill not paid. So there is certain issue and that's a serious issue. But I think looking at the consent of time, yeah. But we have to give some concession because if we fight on mera bill to itna hi tha, aapne itna hi dena, again there can be problem. Patient may die then and there only. That time again the fighting will be there and lot of litigations possibilities will be there. So I think somebody has said that we have to foresee the complication. Why we want to transfer? So communicate the need of the transfer. Take signature of the relatives why we are going to transfer. Proper referral note. I think nobody has told this.
We have to. Yes.
Referral note.
Referral note has to be done
with date and time.
Date and time. And the procedure. And the procedure you have performed with the patient.
And what treatment you had given previously in your hospital, in short. In one case, the
and what
patient
facility
said,
you don't have that you are not able to provide to the patient, and for why you are referring the
so
patient
your
to the higher
infrastructure,
center.
whatever help you have given and whatever infrastructure not supporting to the patients as per the patient's
need.
demand.
Yeah,
Okay.
need.
But in one case, what they made in labor, patient 9:30 was the referring. Means the doctor had referred the patient at 9:30 a.m. The patient's relatives wasted 3 hours. मेरे सास को आने दो, मेरी बुआ को आने दो, मेरे हस्बैंड को आने दो, and patient got transferred to tertiary care after 2 hours. That wastage of 2 hours, patient died on the way. But the wise doctor had written every time, I am going to transfer the patient, she is waiting for her husband, she is waiting for her mother-in-law, waiting for sister-in-law. Every time they explained all these things, so the doctor was not held responsible because perfect documentation of referral, perfect documentation, patient's relatives not going to sit in the ambulance also. Everything was arranged, ambulance is waiting outside. But the relatives were not ready. मेरी ननन को आने दो, मेरी सास को आने दो, मेरी इसको आने दो. So the case was not, they did not go against the doctor because the documentation was perfect. So this is a usual case. Labor में तो बहुत बार ऐसे होता है. देखो ना डॉक्टर आप क्या होता है क्या, देखो ना डॉक्टर आप क्या होता है क्या. Then they say no something has happened. No, चलो दौड़ने के लिए मारने के लिए तैयार हो जाओ. So proper referral note, inform the referral tertiary care center. Madam has given that point. Accompany the serious patient with competent person in well-equipped hospital with proper referral note. So proper referral note will again save you, doctors, if by chance there is some problem during the transit, because we have sent a competent person with the patient, still the accident can occur. But the documentation and proper, all these things, part of documentation is very important, so that even if the patient's relative go into court of law, they will save you as your defense. Now the third question, will you transfer dying patient to higher center? Will you transfer dying patient to higher center?
Yes, ma'am, we'll transfer the patient to a higher center.
Dying patient.
Yes,
okay.
ma'am, we can refer the patient to the higher center because if we don't refer and...
My question is, will you refer dying patient to another hospital? Any more answer?
But before transferring the patient, whatever the essential medicine to save the life of the patient must be done. And everything, whatever we are giving,
that
should be documented.
That you have done. Whatever best you can give, you have done. And but in spite of the good treatment, prudent care, we say.
Communication with the patient's relative must be done. Why we are sending the patient to the higher center.
Any answer from audience?
Ma'am,
you will not transfer dying patient. Why the reason? Yes, correct. So we'll never transfer dying patient or about to die patient. It will create problem for everybody, for the referring doctor and the receiving doctor, because already days on the way, because the patient was about to die, just last कुछ चल रहा था, चेस्ट कॉम्प्रेशन, एड्रेनलिन सब चल रहा था. नो अपने के क्या बोलते, कट नहीं होना, यहाँ पे हम मराठी में बोलते वैसे. चलो शिफ्ट टू हायर सेंटर. नेवर डू दिस टाइप. यस मैडम, यू वांटेड टू टेल सम. But I think, madam, this we have discussed in the previous slide, transfer the serious patient. But dying patient, we can explain, we have taken all the care, all the injections, everything we have done. But the prognosis is very bad, we take signature of the relatives. Still the relatives are asking, no, हमें दवाखाने में लेके जाना, that is their consent. But we are not going to transfer the about to die patient because it may increase the problems for everybody. Referring doctor, receiving doctor. दोनों जगह दंगल हो सकते, यहाँ भी दंगल हो जाएगी, वहाँ भी दंगल हो जाएगी.
Ma'am, therefore there is a role for...
Yes, madam. Madam, on the contrary, I think...
Early referral is the key actually. actually early referral.
I think we are confusing with dying and serious patient. Government hospitals are better protected because they are telling everything. वो तो ज़्यादा से ज़्यादा signature लेने में उनका time जाता है. 5 minutes. So we'll finish. We are going to finish within 5 minutes. So one more question we'll take and then we'll go. So madam, what you said correctly, it is happening everywhere. But I think
all the nursing homes don't have ruskus at that point and they want to refer. Is it?
My question was straightforward. Dying patient means the patient is going to die within few seconds. That was my question. So never shift about to die patient. On the contrary, you explain everything, write down everything on paper. Take signature of relatives from time to time. What treatment you are giving? How is the prognosis? What are the comorbidities that are not, because of that they are not responding to your treatment? This will save you in the court of law, even if the patient is ready to go into court of law. But you are referring the patient who is about to die. In few seconds, it will create problem for everybody. So never refer such type of patient who is going to die within next few seconds. And there can be death because the patient, मैंने देखा है patient ने just hospital छोड़ दिया, patient की death हुई है. यहाँ पे भी problem आता है, वहाँ पे भी problem होता है. Okay? So the last slide we'll discuss. I have my flight also, and again there are some lag behind, so we have to cover the whole program. So next question: patient XYZ brought to government or private hospital. He can be brought to government hospital or private hospital, OPD. You examine the patient. You found no signs of life. Will you refer her to a higher center? Broad dead.
No.
I am talking about broad dead patient.
Yeah, he is already died patient, but we should take the steps that will that assure the patient attended. We should try to give cardiopulmonary resuscitation steps, so or other emergency medicines.
Confirmation
and
is the most
at that
important.
meantime,
Confirmation is most
if
important.
flat ECG record should be monitor should be applied. And in the meantime, an expert should communicate with the patients and patient relatives that the patient condition is such and such.
Not condition, patient is already dead.
Already dead, yeah. No signs of life is there, but we are trying some, if may.
Actually speaking,
Madam, first we have to see the patient. We have to see the patient and explain it to the attendant that there is no signs of life. You can see there is no pulse, there is no respiration, there is no
yes,
breathing.
correct. Once you say we will try, then they will think a patient was alive, and you said you try means something has happened in your hospital.
ECG is flat and there is no signs of
That
life.
is the evidence, though it is not mandatory. Yes, sir? See, when we are MBBS,
What are the modalities that you would apply on that particular patient, and then you declare that this patient is broad dead? So it will take some time. So what you are saying is perfectly all right, that you should ask the patient relatives or inform that probably it seems that he or she is no more, but we need to confirm.
so you can
And
call
if you
physician.
declare that she has been brought dead, please do not charge anything for whatever modalities you use to confirm your diagnosis that he or she has been brought dead.
That is a sensitive
Yeah.
thing
No,
because
not
patient
sensitive. This
dead
is,
body is
this
there.
is sensitive,
We will
this
all
is
know.
legal, this is medical
Yes,
legal,
legal.
this is everything.
So we have to
Sometimes it
confirm
may
the death.
happen. Sometimes it may happen. आपकी सिस्टर ने देखा है, सिस्टर आपकी बहुत कॉम्पिटेंट है. शी इज़ वेरी कॉम्पिटेंट, ANM या ब्लू बेल्ट. शी सेज डॉक्टर साहब पेशेंट तो गया है, ऊपर से नीचे आने की जरूरत नहीं. इज इट करेक्ट? सो
And make documentation also, flat ECG.
Yeah, that
should be
madam
there.
has told. So what my intention was, never treat that broad dead patient is not patient of your, not brought to your hospital. It is brought to your hospital. Our service is to see the patient, attend the patient, and humanity purpose we should not charge anything.
we-
Already
we
broad
can't
dead
issue
patient.
death
Just you
certificate
have to
for this.
confirm whether the death is. You can call your physician immediately if you want to take help of physician. But again, yeah, ECG recording, though it is not mandatory in the court of law, but anything you means you have as a evidence, any document that will help you. If suppose the relatives go into court of law, that is the ECG, flat ECG. Okay, so the issues are whether to inform the police, cause of death, can you give, Next is issue death certificate, records to be kept. First is whether to inform police. Patient brought dead.
Yes, we should inform the police. And we can't issue death certificate to that patient.
No, the point was inform the police. Yes,
Yes, we
we
should
have to inform the police because there can be foul play, there can be natural death, who knows. Better to inform police. Then they will see and then the relatives can say, if by chance the patient is very old, patient known to you, you have treated the patient n number of times, you know the cause of the death, still, I will say, still, in today's world of defensive, no, though we should not practice defensively, but still, if you want to confirm, better to inform the police because there can be some foul play again. We don't know what has happened in the home. Okay?
We have to give the dead body carrying certificate whenever there is a suspicion of death patient is and anything is recommended at that time. They see the parent not have any problem on the way to carry. So dead body is carrying certificate.
अभी तो बॉडी जा नहीं रहा है, अभी तो डेथ सर्टिफाई कर रहे हैं, अभी ले जाएगा तब ना, सर्टिफिकेट अभी नहीं दे रहे हैं, अभी तो पुलिस को इन्फॉर्म कर रहे हैं.
Cause of death we don't know, we have to inform police. Just 1 minute, last 2 points. So never issue death certificate unless you know the cause of the death. Inform police. You can write probable diagnosis. But if you don't know anything, ask for inform police. That is the that police and relatives will decide. Your duty to inform police because you don't know the cause of the death.
If there is an unnatural death, a young person, unexpected young person, you see some medical legal issues might arise, this should be informed.
So better to inform
a chronically ill patient above 90 years who is surrounded by his family
members. That's what
members,
I said. We know the patient, senile patient. Already you have examined patient n number of times. That time you may give. Not mandatory, but you may give because it's very family known to you. So we'll end the discussion. Last slide. Always attend the patient. Do not delegate. Prepare only OPD case paper. Don't admit the broad dead patient. Okay. 2 identification marks of the dead body. You can record. Details of the accompanying person, whether he is rickshaw wala, mama, kaka, whatever. 2 identification marks of the accompanying person also, and the signature of the accompanying person. Signature of 2 witnesses. Always avoid hospital staff because again they will be biased as per the law. So always take witness signature of other relatives also you can take. Write down the history given by the accompanying person. Declare death after careful examination and auscultation. ECG recording if possible. If any suspicion, inform police. If the disease is known to you or under treatment for some illness, you may give. Preserve OPD record carefully. The investigating officer, there can be some domestic problems. He may ask you, what are your findings when the patient arrived to you broad dead? So always record, always keep the OPD record carefully. You may be required to attend the court of law in future. So preserve the OPD record. So the crux of the whole situation, do not avoid attending broad dead patient. Don't issue DC if you don't know the cause of the death. Be careful about records at each and every step. Inform police in case of unknown person, any foul play you are suspecting. Always cooperate with the law. Here I will conclude. Thank you for the opportunity. And sorry panelists, because of want of time, we could not take all the cases. But you wonderfully participation for all of you experts. And of course, Dr. Nupur was there. Thank you so much.
Can I request the panelists and the moderators to please join us for a photograph next to the backdrop?
So once again,
yes,
thank you, Dr. Meena.
Can I request the chairpersons for the next session to please join us on the stage? We have Dr. Shamal Seth, Dr. Nutan Narayan to please join us. Can I also request our speaker, Dr. Pragya Mishra Chaudhary ma'am to please join us? And we would like to also take this opportunity to thank Dr. Shamal Seth sir as well.
With the permission of the chair and Dr. Pragya, may I request our President, Patna Obs and Gynae Society and Organizing Chair, Dr. Meena Samant, and Organizing Secretary, Dr. Amita Sinha to kindly come on stage for a minute. Dr. Pragya, please come on stage. All of you know that Dr. Shamal Seth sir is the incoming Vice President 2025 of FOGSI and Patna Obs and Gynae Society and POGSCON 2029 team wishes to felicitate sir. May I request sir to come forward?
Basically, I will be the Vice President of the East Zone, and that East Zone includes Patna itself. It's not only Bengal or whatever, entire East Zone. So thank you all so very much for making me
Sir,
Vice
please.
President from East Zone unopposed. Thank you very much. And it's my pleasure to receive this award. Now, I started my Foxy career in Patna in the year 1991 when I was a postgraduate student over here. And coming back again to Patna time and again, and now receiving this. Thank you very much. Progya, thank you so much. Yes, yesterday it was I missed actually. Thank you so very much. Thank you. Thank you. Thank you. Thank you all. Thank you.
Satish, shift kar. Sir ji. Chalo. Yes, we'll start with the session.
Please come. Please come. So, good afternoon, everybody. We're just waiting for the lunch. After this session, I believe we'll have lunch. And this session, we'll have the president, the newly launched president of the Patna Obstetric and Gynecological Society, my colleague, Dr. Progya Mishra Chaudhary. And she will be speaking on broad spectrum female fertility nutrition. And may I request Dr. Nutan Narayan to introduce Progya. I believe this audience does not require any introduction for her, but still, it's a formal introduction, Progya.
Of course, everybody knows Dr. Pragya. I just want to highlight the important points. She is the Secretary General of ISOPAP right now, and she is also the Chairperson Genetic and Fetal Medicine Committee. And right now she has been elected President of POGS, and she has been awarded a lot of certificates, and she is the most able and academically very, very good. And I don't want to take excess time, but she is very good. All of us know that. Carry on, Dr. Pragya.
A very good afternoon to all of you, revered chairpersons, for the kind introduction. And I know it's lunchtime, so I've just gone to that side and hidden quite a few slides so that I can make the presentation brief. This is a sponsored session by Acumentis on broad spectrum female fertility nutrition. Now there was, it was published in the Journal of Human Reproduction in 2019, where they had done a cross-sectional observational study in an infertility clinic in a medical college and government hospital. What they found that about 33% of the it's mainly because the causes, the distribution wise, it's because of unexplained infertility, and 10% is both male and female, and only male about 9%, and only female, rest of it, the major chunk is due to only female causes. And on the right side, where they did a breakup, and what they found that 20% was due to uterine malformations, and about 33% it was due to tubal factor, and 46% due to PCOS. I mean, none of us would deny that PCOS is a real emerging problem, especially for the Indian subcontinent. And almost 20 out of 100 young women are actually suffering from PCOS these days. So WHO also performed a multinational study to determine female infertility etiologies, and WHO also found that ovulatory disorders were responsible for 25%, then endometriosis 15%, pelvic adhesions 12%, tubal blockage 11%, other tubal or uterine anomalies 11%, hyperprolactinemia 7%, and idiopathic is still responsible for almost 20% of the causes. So, as I said that, many a times it's related to ovulation. So, what are the reasons for this faulty ovum or ovulation? It's because of oxidative stress, then oocyte maturation failure, where in IVF, the ones who are the IVF specialists would know that many a times, the oocyte fails to develop. Then poor quality oocyte, then it's quite disheartening. Then poor ovarian reserve, and because of an ovulation. So there are common barriers in the journey of motherhood, and these multiple barriers, now there are multiple solutions, because many a times, it's the nutritional factor which actually helps in overcoming these multiple barriers which are responsible for poor ovarian reserve and oxidative stress, failure in fertilization, implantation, impaired ovulation induction, poor ovum quality, then limited ovum retrieval, and poor IUI IVF outcomes. So there is emerging role of nutraceuticals to overcome these barriers. So, and what are these? Like now melatonin, it has been found that melatonin protects the cells from oxidative stress by acting as a free radical scavenger and by stimulating antioxidant enzymes. So Hemadi et al. Reported the improving effect of melatonin on the primordial follicles of the ovarian graft as it facilitates their development to the next morphological state. And melatonin significantly increases M2 oocyte counts and grade 1 embryo ratio, thereby improving the oocyte and embryo quality. Then melatonin improves the oxidative balance in the follicular fluid, since it is capable of restoring concentrations of diverse markers of oxidative status, and it also improves oocyte quality and consequently the amount of transferable embryos. So melatonin slightly enhances the success of ART. And following IUI, melatonin treatment has a favorable effect on mature follicles, endometrial thickness, and pregnancies in infertile PCOS women. So we cannot undermine the role of melatonin in improving female fertility. There was a study which was a prospective randomized controlled clinical trial, and in which, to one group they gave 3 milligrams of melatonin from 3rd to 5th day of the menstrual cycle until the HCG injection, and group B did not receive any melatonin. So what did the results show? That melatonin groups significantly had higher mean number of retrieved oocytes, significantly higher mean M2 oocyte counts, and significantly higher grade 1 embryo ratio. So it concluded that IVF patients definitely benefit from melatonin in improving the oocyte and embryo quality. Then coming to coenzyme Q10, well, a lot of us are already prescribing a coenzyme Q10, which acts as an antioxidant. So it is a lipid-soluble quinone, and it is reduced to ubiquinol during or after absorption in the small intestine. The reduced form represents approximately 95% of the circulating CoQ10 in humans, and ubiquinol has greater bioavailability than ubiquinone. So CoQ10 supplementation has long been used to ameliorate infertility outcomes associated with an increased clinical pregnancy rate. And in the clinical setting, CoQ10 supplementation led to better response to ovulation induction in 35 to 43-year-old women. So does coenzyme Q10 supplementation improve fertility outcomes in women undergoing ART? There was a systematic review and meta-analysis of RCTs. So again, in this study, the results showed that CoQ10 oral supplementation led to an increase in clinical pregnancy rate when compared with placebo, so 28% versus 14%. Increased And honestly, my experience, not because this is a sponsored session, but otherwise also, I'm saying that I've prescribed, CoQ10 to so many women, and actually it has done wonders, 3 months of coenzyme Q10 supplementation. So it increased the mean number of mature follicles and ovulation rate per cycle. It also increased the median number of day 3 high quality embryos, and there was no difference between groups was observed regarding live birth rate and miscarriage rate. So does coenzyme Q10 supplementation improve fertility outcomes? So it could act as a protector of ovarian reserve from the adverse effects of aging. And this study concluded that oral supplementation may increase clinical pregnancy rate when compared with placebo or no treatment in women with infertility undergoing ART procedures without an effect on the live birth rate or then N-acetylcysteine. It also improves oocyte quality through antioxidant action, leading to high quality blastocysts by improving the GSH content. And N-acetylcysteine can improve the sensitivity of the ovary to exogenous gonadotrophins in advanced stage women, which may be helpful to promote oocyte development capacity. N-acetylcysteine is a safe, well-tolerated drug that could be a potentially effective adjuvant treatment by improving the overall reproductive outcome in women undergoing unilateral, even laparoscopic ovarian diathermy for clomiphene-resistant PCOS. And NAC is effective in inducing or augmenting ovulation in polycystic ovarian syndrome patients. So there was a study which was a prospective randomized study where they gave to the treatment group, they gave 0.6 grams of N-acetylcysteine 3 times daily from the menstrual phase of the previous cycle for 45 days using the GnRH antagonist protocol, and the control group, same protocol without N-acetylcysteine. So the results showed that in the N-acetylcysteine treatment group, the blastocysts were of high quality and the follicular fluid glutathione content was also higher, giving rise to better pregnancy rates. So in female subjects over the age of 35, reproductive capacity begins to decline and the rate of miscarriage increases. Well, this is a fact which all of us know. And this decline is primarily due to poor quality of oocytes with age, diminished ovarian reserve, and decreased developmental competence of oocytes. So here the primary cause is oxidative stress in oocytes, and N-acetylcysteine is beneficial to follicular development. It plays an important role in cell survival through follicular preservation, and it also improves the quality of oocytes and embryos by increasing intracellular GSH, which is glutathione synthetase activity. And GSH is the most popular cellular antioxidant that can reduce the reactive oxygen species. So GSH supplement could prevent oxidative stress in oocytes. So a combination of N-acetylcysteine and gonadotrophin treatment, treatment can, because we are breaking down for lunch, that's why, can improve the ovarian response to superovulation drugs in ART and also in aged populations. Now, what about L-arginine? A lot of us have been prescribing L-arginine to our antenatal patients, even from the time from the periconception, and in fact throughout the antenatal period. But L-arginine also helps with oocyte quality. So the intrafollicular milieu in L-arginine treated patients improves the follicular growth and probably the oocyte quality and fertilization. I mean, at least, what I do, that in most of my patients, when they are planning to, conceive, so from 3 months prior, from the time that you prescribe folic acid, I also prescribe L-arginine to patients. So there is modulation of endometrial vascularity by oral L-arginine supplementation, which may improve the pregnancy rate. especially in poor responder patients who normally present an impaired uterine perfusion. So I think we can leave this. Basically, the results, another study which showed that L-arginine treated groups in IVF showed lower cycle cancellation rate, significantly higher number of oocytes and transferred embryos, increased plasma and follicular fluid concentrations of arginine, citrulline, nitrous oxide and nitric oxide, and insulin-like growth factor 1. So L-arginine definitely in IVF patients, it helps in poor responders. So, and nitric oxide is an established regulator of ovarian function, and in that study what they showed that L-arginine oral supplementation during ovarian stimulation induced an increase in plasma L-arginine, L-citrulline and nitrate levels, and nitric oxide acts as a vasodilator, increasing what it does, that it increases the permeability of follicular epithelium to plasma proteins, and as the follicles mature they become more permeable to plasma proteins and result in more susceptibility to circulating FSH and growth hormone action. The simultaneous action of FSH and GH may promote an increased production of IGF-1, and growth factors such as IGF-1 play a role in follicular maturation and differentiation. So the conclusion of the study was that oral L-arginine supplementation may improve ovarian response, endometrial receptivity and pregnancy rate. Now what is this resveratrol? It shows therapeutic potential in female infertility related conditions, and based on studies, resveratrol presented beneficial effects again on follicular pool and oocyte quality in age-related infertility due to its effect on the mitochondrial membrane potential, ATP, oxidative stress levels, and reduced inflammation. In another study where they gave daily nutraceutical supplementation containing resveratrol and folic acid, vitamin D, vitamin B12 and B6. So the treatment group which received resveratrol supplement in the preceding 3 months of IVF cycles, control group did not receive any supplementation, and what they found, the results showed that the group which was supplemented led to differentially expressed mRNAs, and functional enrichment analysis showed differentially expressed mRNAs may regulate several pathways involved in fertility. The mean number of fertilized good quality oocytes significantly increased from 63% to 80%. So resveratrol may act on mitochondrial mRNAs to improve follicular microenvironment, and it may improve oocyte quality and pregnancy outcome. Omega-3 fatty acid supplementation, that also has an effect on fecundability. It may present a feasible and inexpensive modifiable factor to improve fertility. What about effect of diet and nutrient intake on women who have problems of fertility? There was a study to investigate the association between nutrient intake and women's reproductive outcomes. Then there was a questionnaire-based study on 120 women, and the results showed that nutrient intakes were higher in fertile women, and highly significant result was found in nutrient intake of zinc in fertile women. Higher percentage of infertile women had less zinc intake. So the study concluded that nutrient intake may be important, may be an important modifiable factor that can significantly show positive impact on women's reproductive health. So then the vitamins, which are some of the potent antioxidants, I think this learned audience, I don't have to tell them that vitamin C, vitamin D, and vitamin D, they all act as antioxidants because they reduce the free radicals, and that's how they help in female fertility solutions. So and some of them are, others are selenium, chromium, zinc, and so the selenium and zinc have antioxidant activity. So I think this is coming to my last slide, because this is a sponsored session. So we'll have to take the name of the esteemed sponsors, which is Acumentis. They have come up with the lineator F. They already had lineator for male fertility and lineator sachets for male infertility. So now they have come with this lineator F sachet for female infertility. So empowering every step towards motherhood. I think most of the drugs which Acumentis comes up with works very well, in female fertility, because I've tried, using their combination of metformin and myoinositol in thousands and thousands of PCOS patients, and actually it has done wonders. So, but I have not tried lineator F. This is a new product. So let's see, how it works. So thank you so much for a very patient listening, and the people who have stayed back before lunch. Thank you so much.
Thank you very much, Pragya. As usual, it's very informative, compact, and to the point. Yes, we all know the value of these micronutrients for the fertility in both partners, be male partner or the female partners, and these are available in different combinations with the different kinds of micronutrients with other preparations. Thank you very much. I believe we should come to the end of this session.
Yes.
Nutan, you would add anything?
No, you have given a very good lecture, and I'm sure all of us are going to try this lineator F now.
Holding
And,
slide, dal de.
I think we should.
And we're
Thank
going to
you
take
very
pictures
much.
with the chairperson. I believe Dr. Pankaj Desai is also waiting and listening to your talk. So can I request Dr. Pankaj Desai sir also to please join us? Can I request Dr. Ranjana Sinha ma'am, Dr. Amita Sinha to also join us on the stage for a picture? Yes. On the stage. Now the lunch is going to be started. So please come back over here by 2 o'clock. Dr. Meena Samant, can I request her to please join in? Just thoda sa hold karo, wait. Doctor, yeah. Don't. I know Dr. Shamal has a flight to catch as well. Thank you so much.